Yeah, we are live. You can start.
We're live.
Yes, yes.
A very warm greetings to everyone assembled here. I'm Shrigiri Venkatani Harika and my co-moderator Srinidhi. We both take the privilege of comparing the clinical case presentation competition session 2 at Med-Invade 2021, organized by Squad Medicine and Research. Today, I'm so pleased to introduce you all to an honorable judges, Dr. Richa Chauhan, MBBS Gold Medalist, DNB, Radiation Oncology. Currently, she is a senior consultant, Department of Radiation Oncology, Academy in charge, Mahavir Cancer, Sansthan, Patna. She's been selected for Dr. D.C. Pant Award for the Young Oncologist at the National Conference Association of Radiation Oncologists of India at Jaipur in 2011. Awarded with Dr. Arpita Roy Award for Cancer Research and Awareness in Bihar in 2014. And she was presented with YROC Proffered Best Paper at the National Conference Association of Radiation Oncology of India at Bhubaneswar in 2016. Ma'am has 52 publications and 28 paper presentations in the various national and international journals. And she's organizing secretary of the National Conference of the Cancer Care India, Patna, in 2017 on 17th on 18 December. We welcome you, ma'am, to today's session. Now, I would like to introduce you all to another eminent personality, our honorable judge, Dr. Lolita Matiashova, intern, Department of Therapy, Professor, Hospital of Emergency Medicine Care. She is a member of a European Society Cardiology, member of the Counseling of Young Patients GI, LT Mala NIT, NAMSU 2020 at present. She has got 33 scientific publications for the Congress and conferences and 6 peer-reviewed articles, and she has participated in 33 international conferences. I'm so honored to list her various works, which include COVID-19 vaccine in the Ukraine, effects of yoga and resistance training on the blood lipid levels, effects of intermittent fasting in type 2 diabetes mellitus, human-machine interaction for health and beyond the orbit. We welcome you, ma'am, to today's event. So without any delay, we are starting with the today's clinical case presentation competition. And I request all the participants to carefully listen and adhere to the following rules. First, a PowerPoint presentation must be made with the first slide mentioning the title, authors, and the conference name, and the second slide mentioning that the case is original and is done by you and not someone else's work. Second, there's no slide limit. The font size must be 24 with 1.15 space. The video must be on during the presentation, and the presenters should ensure better connectivity and join. And we will not be held responsible for any bad connectivity on your end. The screen will be shared by the individual presenters for the papers. In the case of any difficulty, host will share the screen with a prior request. And please strictly adhere to the time limit. Remember, we are not exceeding the time limit, and the time is very precious to the participants. So please listen that the time limit is 4 plus 2 minutes. That is 4 minutes is for presentation and 2 minutes is for Q&A round. So please be present 20 minutes before your case slot. And the criteria for the judging include: first is originality and novelty of case content, that is 25 points. Presentation, which includes comprehension, appearance, that is of the slides, which should be legible, and it should engage the audience, which consists of 50 points. Discussion, which includes Q&A session, answers by the presentee to the judges' questions, which includes 25 points. So in total, it's divided into 25, 50, and 25, which includes 100 points. So I request the judges to mark the scores of the participants in a piece of paper for the final evaluation of the participants. I hope it's clear to each and every one of you, especially the participants. So now we are starting with the clinical case presentation, and I would first like to call our participant, Suman Mandal, to present the case and ask our next participant, Sana Sultana, to get ready with the case presentation. So Suman Mandal, are you ready? Suman Mandal?
Yes, I am ready.
Okay. Just share your screen and switch on your video.
Hello, I am visible.
Yeah, you're visible and audible. Just share your screen.
Is the screen visible?
No, the screen is not visible. Just try once again.
Please proceed for next participant.
Okay. So now I request Sana Sultana to get ready with her case presentation, and I ask our next participant, Aditya K, to get ready with his case presentation. So Sana Sultana, are you ready with the case?
Yes. Hi, am I audible?
Yeah, you're audible and visible. Just share your screen.
Is my screen visible now?
Yeah, your screen is visible. So, okay. Your time
Can I
starts.
start?
Yeah, your
Good
time
evening,
starts.
graduates. I'm Sana Sultana, a fourth-year MBBS student from Ramaya Medical College, Bangalore, and under the guidance of Dr. Vishwanath K, I will be presenting a case from the Department of General Medicine. Chief complaints: a 50-year-old man hailing from Bangalore presented with chief complaints of bilateral swelling and pain of lower limbs since 4 months.
Sana, you're not audible. Sana, you're stuck. Am I audible to you?
To proceed with next participant, you can take next Sumant and Sana.
Okay. Yeah. Aditya K, are you ready with the case?
Yeah. Can you see me?
Okay. So I would like to request Aditya K to present the case, and I request our next participant, Milana Veronica, to get ready with her case presentation. So Aditya,
1 second. Let me just start the slideshow.
Sana, just stop sharing your screen. I'll call you some other time.
Can you see my screen?
No.
Uh,
Sana, please
I
stop
can-
sharing
Yes, I
your
can
screen.
see.
so can you see, sir?
Yes.
Yes, we can see.
Okay.
Just 1 second. Yeah. Okay. Shall I start?
So can you keep the time record, because I'm not able to see his screen.
Okay.
Hello?
Yes, please start.
I'll start now, sir. Okay, fine. A very good evening to one all present here. I'm Aditya, a final year medical student from Ramaya Medical College, and I'll be presenting the following case report. A 47-year-old male presented with breathlessness and pedal edema since 2 months. The patient presented with breathlessness since 2 months, which was insidious in onset, progressing from NYHA class 2 to class 3. Patient also presented with bilateral pitting painless edema of the lower limbs, progressing up to the knee. There's no history of fever, hemoptysis, V's, syncope, URTI. Past history, family history, as well as the personal history was insignificant. Examination showed bilateral lower limb pitting painless edema with JVP elevated and rapid XY descent. The systemic examination showed mild hepatomegaly with the bilateral basal crepitations. So investigations were performed, the first of which was an ECG, which showed low voltage complex in the limb veins. Hence, this led to the performance of an echocardiogram, which showed significant diffuse fine granular appearance of the myocardium, normal left ventricle with normal contractility, and restrictive left ventricular filling physiology with biatrial enlargement. A diagnostic coronary angiography was performed, which showed insignificant coronary artery disease. Hence, a cardiac MRI was performed, which led to the late gadolinium myocardial enhancement. The test that clinched the diagnosis was the endomyocardial biopsy, which shows mild patchy deposits of myeloid SSA in the myocardial interstitium. This is a picture of the ECG, which shows the low voltage complex in the limb leads. This is a video of the 2D echo. This is again the 2D echo showing biatrial enlargement with normal sized ventricles. This is a 2D echo with strain imaging, which shows reduced global longitudinal strain as well as apical sparing, also known as the cherry red spot. This is a biopsy report showing the presence of myeloid SCC in the myocardial interstitium. Hence, we came to the diagnosis of restrictive cardiomyopathy secondary to amyloidosis, also known as stiff heart syndrome. The treatment was mainly symptomatic, which involved fluid and salt restriction and a full course of furosemide 20 mg OD, as well as eplerenone, which was 25 mg OD. The patient was followed up after 4 weeks and showed symptomatic improvement. He was counseled about his prognosis and the possible need for a cardiac transplant. Coming to the discussion, amyloidosis is a rare disease with amyloidosis disease with deposition of beta-pleated fibrils of various proteins in the extracellular space of organs, causing organ dysfunction, leading to morbidity and mortality. Of these, cardiac amyloidosis is considered a rare disease with an annual incidence of 8 to 10 cases per million population. Based on the type of amyloid protein, it can be classified into 5 types: amyloid light chain or AL, transthyretin type, TTR, systemic senile amyloidosis, isolated atrial amyloidosis, or the serum amyloid A. The clinical features of cardiac amyloidosis is mainly that of congestive cardiac failure, which shows exceptional dyspnea and autopnea, fatigue, and weakness. Abdominal distension and lower extremity edema may also be seen. Diagnosis usually requires a high index of clinical suspicion with echocardiographic clues, as are like diastolic dysfunction, biatrial enlargement, as well as ventricular thickening. Diagnosis also involves ECG, cardiac MRI, as well as myocardial biopsy, considered the gold standard. Treatment is usually two-pronged. One is the treatment of symptoms arising from cardiac dysfunction, which is usually diastolic, with a combination of loop diuretics as well as aldosterone receptor antagonists. The other is the treatment of the underlying amyloidosis, for which multiple agents have been studied or are in late phase trials. These include diflunisal, which is an NSAID which stabilizes the TTR molecule, and tafamidis, which is a TTR tetramer stabilizer, which binds to a TTR molecule and stabilizes tetrameric structure, both of which prevents the amyloid fibrillogenesis. We also have patisiran, which is an RNA interference agent, which helps to decrease the production of transthyretin by the liver. Hence, in conclusion, I'd like to state that cardiac amyloidosis is a rare cause of heart failure with an annual incidence of 8 to 10 cases per million population. The overall prognosis is poor, with the median survival from time of diagnosis to be about 4 years, mainly due to its elusive diagnosis as well as unsatisfactory treatment modalities. Hence, there should be a high degree of clinical suspicion and confirmation with imaging as well as biopsy. These are the references, and thank you.
Thank you. I request our judges to proceed with the Q&A round.
Okay, can I start? Got some questions. Thank you first
Thank you
for your amazing clinical presentation. I also first I want to ask what was happen with your patient after diagnosis when he will initiate the initial treatment, yes, and after that, like how he was going, if his edema went or it was still linked with edema.
Yes, ma'am. So after his initial treatment, as mentioned, he came after 4 weeks, and following which his edema and as well as his breathlessness kind of decreased. And at that time, we counseled him regarding his prognosis and the difficulties in treatment of the disease, as well as the necessity of cardiac transplant that he might require.
Thank you. And also, I want to ask, I'm not sure about it. If I'm not mistaken, it's like if patient has amyloidosis, you can't recommend him like any physical activities. Yes, in this case, it's he can't like do.
Sorry, ma'am, I think your voice is breaking.
No, sorry. I mean about like physical activity. If patient has amyloidosis, it's like one disease when you restrict it. Yes.
Sorry, I couldn't get you, ma'am. I'm sorry.
So sorry, it's like maybe some connection. I mean, so this patient has amyloidosis, yes, and sometimes you can find amyloidosis in young patients.
Yes.
And in this case, you can't. Can you recommend physical activity in amyloidosis? And like, I know, not like in this case, generally.
You're saying, can I recommend or can I comment on it?
Recommend to the patient.
I think some amount of, I think you can recommend, ma'am. I don't see why you cannot.
Yes. Okay. Thank you so much for your answers.
Okay. Yeah, Aditya. So that was a nice and quick presentation. Cardiac amyloidosis, very rare case. So what are the usual common sites where we suspect amyloidosis and we see more patients clinically with amyloidosis?
Ma'am, it can be like primary or secondary. I mean, secondary amyloidosis is very common. Usually you see it in either the liver, spleen, or
So,
kidneys.
I mean, just asking, have you seen other cases of amyloidosis? I mean, other parts?
Ma'am, I don't think so, ma'am. This is one case I came across, like by chance, to be honest. But I was lucky to come across it, but I've not been able to see any other case of amyloidosis yet.
Thank you.
Thank you.
Thank you, judges. Thank you, Aditya.
Thank you.
Now I request our next participant, Milana Veronica, to present the case, and I request our next participant, Dr. Reedy Harris, to get ready with her case presentation. So, Milana, are you ready?
Hello, yes, I am ready.
Okay.
I will try to share my screen.
Yeah, just share your screen. Milena, are you able to share your screen? Or shall I move to the next participant?
Yeah, please take someone and the Sana if they can.
Yeah.
Please be quick from person to person. Don't delay. If one
Yeah.
person got postponed immediately after, then take the previous one who rejected. Like after now,
Sure.
we are taking someone and Mandal. So like that.
Okay. Sana, are you ready with the case?
Yes, am I audible now? I'm so sorry about that. I'm not sure what happened.
No problem. Just present your screen. Share your screen.
Okay, one more time. Sorry.
Milena, can you please just postpone your presentation because now Sana is presenting. I'll call you the next time. Okay?
Okay.
Okay. Thank you so much.
Hello.
Sana? Just okay. Yeah, your screen is visible. Your time starts now.
Is my screen visible? Hello.
Yeah.
Hi.
Your time starts now.
Good evening. I'm Sana, a fourth-year medical student from a case from the Department of General Medicine under the guidance of Dr. Vishwanath K. Chief complaints: a 50-year-old man hailing from Bangalore presented with chief complaints of bilateral swelling and pain of lower limbs since 4 months. History of presenting illness: a 50-year-old man apparently well 4 months ago presented with pain of bilateral lower limbs since 4 months, right more than the left. The pain was insidious in onset, gradually progressive, dull, aching in character, constant and severe enough to make him non-ambulatory. The patient also complained of bilateral swelling of lower limbs since 4 months, right more than the left, which was insidious in onset, gradually progressive with no activating or relieving factors. There was no history of fever, trauma, or loss of weight. Past history: patient is a known case of diabetes mellitus and hypertension since 10 years and is on medication for the same. He was also diagnosed with dilated cardiomyopathy and heart failure with reduced ejection fraction 1 year ago. No history of previous surgeries or allergies, no significant family history or personal history. General physical examination, vitals, as well as head-to-toe examination were all normal. No diabetic dermopathy changes were seen. On local examination of the limbs inspection, both thighs were diffusely swollen, right more than the left. On palpation, inspectory findings were confirmed. There was no local rise of temperature. The right thigh was swollen with a diffuse indurated tender mass in the anterolateral aspect. There was no fluctuation of the mass. Systemic examination of the cardiovascular system: S1 was heard. A pansystolic murmur was heard with the bell of the stethoscope at the mitral area of grade 3/6. JVP was normal at admission. The rest of the systemic examination was normal. On investigations, there was leukocytosis and ESR was increased. Creatine kinase was increased. Fasting blood sugar, postprandial blood sugar, and HbA1c were markedly increased. TSH was increased, and on urine routine, nephrotic range proteinuria was found. Fundoscopy showed cotton wool spots, hard exudates, and dot hemorrhages suggestive of mild non-proliferative diabetic retinopathy. Ultrasonography of the right thigh showed myositis in the anterior and medial compartments. On MRI, heterogeneous hyperintense areas involving the anterior and posterior compartment muscles of the thigh, suggestive of pan-myositis with myonecrosis of the thigh muscles was seen. The muscle biopsy of the right vastus lateralis showed chronic inflammatory infiltrates amidst focal areas of fibrosis. With this, a diagnosis of bilateral diabetic muscle infarction was made, ruling out DVT, soft tissue abscess, cellulitis, and pyomyositis. Coming to the management, the patient was managed with bed rest, analgesics, and optimal glycemic control. And follow-up, the pain and swelling resolved gradually over 4 weeks. Coming to DMI, it is a rare complication of long-standing polycontrolled DM, presenting as a tumoriform focal muscular degeneration. It was first described in 1965, and since then, less than 15 cases of bilateral DMI have been reported. Pathophysiology includes thrombosis, embolism, atherosclerosis, and diabetic macroangiopathy, which leads to ischemia, edema, causes an inflammatory response, which leads to further edema and causing compartment syndrome and ultimately infarction. Risk factors include long-standing diabetes for over 15 years, type 1 diabetes, HbA1c of 9.34%, microvascular complications, and it commonly occurs in women. Areas commonly involved include the quadriceps, hip adductors, hamstrings, hip flexors, calf muscles, as well as the upper limb. Clinical features, investigations, and management were the same as outlined in the case. Prognosis, recurrence occurs in about 48% of the cases with 1 to 2 events per year. It is also an indicator of poor long-term prognosis, as most patients die within 5 years of diagnosis due to significant vascular compromise. Conclusion, there are an estimated 73 million cases of diabetes in adult population of India. Diabetic myonecrosis is a rare complication and there's a relative lack of awareness about it compared to other complications. Hence, it is either misdiagnosed as only heart failure or there's a delayed diagnosis, which in turn increases the morbidity associated with the disease. Therefore, it should be included as a differential in known diabetics with poor glycemic control who present with swelling and pain of lower limbs, especially. Since it is an indicator of poor long-term prognosis, adequate glycemic control and close monitoring is required. These are my references. Thank you.
Thank you, Sana. Now I request our judges to please proceed with the Q&A round.
Thank you.
Thank you so much for your amazing presentation. Actually, I heard all this complication. Now I will think about my patient about it. And also, after treatment, you say swelling is went through, and after that, the legs was similar. Oh no, I'm curious.
Ma'am, so basically the treatment only was considered of bed rest and analgesics, and then the swelling gradually, and finally it basically was that your question? I'm so sorry.
Okay, so it's something was with my internet connection. I will try. Can you repeat it, please? Okay, we'll screw it because it's something with internet connections. Thank you so much for your presentation.
Thank you, ma'am.
Okay, Sana, a very rare case indeed. So I just want to know something more about the treatment. Any role of antiplatelet or antithrombotic therapy and what you used in your patient? You're quite fast.
Yes, ma'am. Thank you, ma'am. Ma'am, so basically there are 3 modalities of treatment. With our patient, the patient was treated with only bed rest, analgesics, and for further glycemic control. There have been cases where they have tried antiplatelet drugs as well as steroids, but it increased the median range of recovery from a period of 5.5 weeks to about 8 weeks in cases where there was a medical management include. And in cases where surgery was included, further prolonged the period of recovery to about 13 weeks. So there was a conclusion which said that the best probably management was supportive management with only bed rest and analgesics. And further, even biopsy, in a lot of cases, biopsy was done to come to the diagnosis because it had the highest specificity of 95%. But even biopsy showed that there might be a delay in the recovery period. So with all of this, I think the management was summarized as only bed rest with analgesics and biopsy to be avoided unless necessary, ma'am.
But your patient also had DVT, I suppose, no?
No, ma'am. It was just a differential diagnosis because there's a differential diagnosis, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you, Sana, and thank you, judges. Now I request Suman Mandal to present case, and I request our next participant, Aditya K, to get ready with his case presentation. So Suman Mandal, are you ready?
I already presented my case, Aditya K.
Okay, sorry. Aditya presented the case, right? Okay. I request our next participant, Dr. Rini Harris, to get ready with the case presentation.
Please proceed with Milena or someone. I
Suman?
think. Okay.
Yeah, I'll share the screen. You just have to present the case, okay?
Okay.
Please keep on track time you only. I'm not keeping.
Yes, sir. Is it visible, Suman?
No, madam.
Now is it visible?
Now it is visible.
Okay. Just a minute. Okay.
Okay.
Your time starts now.
Hello.
Yeah, your time starts now.
Okay. Good evening, honorable judges and distinguished delegates. Myself, Suman Mandal. Today, I am presenting a case of Stevens-Johnson syndrome that occurred due to use of a very common anti-epileptic drug, that is carbamazepine. Next slide.
Is it visible?
Yes. Okay. Though carbamazepine is highly popular first-line anti-epileptic drug, we must have to remember that no drug is immune from side effect. So my motive for presenting this case is to increase the awareness about this rare but serious adverse event while using carbamazepine, that is Stevens-Johnson syndrome. Next slide, please. Now coming into our case, a 10-year-old female present with extensive rash on face, oral mucosa, neck, chest and abdomen and legs. Also there was fever and cough. Next slide, please. Since last 5 days, she was suffering from fever with continuous cough, which was managed by amoxicillin and clavulinate composition and also paracetamol. Also there was a history of seizure, and for that she was given carbamazepine. After taking that medication, within 6 to 8 hours, multiple rashes started to develop almost all over the body. Next slide, please. In physical examination, we had found oral ulceration along with hemorrhagic crusts over lips, maculopapular rash over face, and target-like lesions over extremities and trunk part. Also, dryness of mouth was also noted, and along with some conjunctival hemorrhage and purulent discharge in eye. Next slide, please. Let's see the laboratory investigation of the patient. Hemoglobin level. Next slide, please. Hemoglobin level and platelet count both are decreased, but C-reactive protein level are increased. Also, echo revealed that mitral valve prolapse with trival mitral regurgitation. Next slide, please. Next slide. So our provisional diagnosis is carbamazepine-induced Stevens-Johnson syndrome. Also, casualty assessment is done by WHO EMC scale. That is possible. Next slide, please. Now coming into our treatment part. Firstly, carbamazepine was withdrawn and started our management accordingly, like administering IV fluid, paracetamol, IV ceftriaxone, mupirocin ointment, and metronidazole ointment. Next slide, please. After that, she was referred to high dependency unit where she was given intravenous immunoglobulin in appropriate doses. Next slide. Now at our differential diagnosis, that is erythematous multiforme, amoxicillin clavulinate induced Stevens-Johnson syndrome, staphylococcal scalded skin syndrome, and toxic epidermal necrolysis. All are excluded. Next slide. She was followed up for almost 8 weeks after her complete recovery, and also asked her to visit dermatology OPD for skin discoloration and scarring management. Next slide, please. So we have to keep in our mind about this rare but severe entity while treating with carbamazepine, as if early diagnosis is possible by closely monitoring our patient, and adequate steps can be taken to save our patient's life. Next slide, please. Here is our disclaimer. And next slide, please. Here are my references. And next slide. Thank you.
Thank you, Suman. I request our judges to continue with the Q&A round.
Thank you so much, Saman, for your great presentation. And also I want to ask you, so when you realize that this was from carbamazepine as a side effect, how you was controlled her seizure, this patient, because you should have disconnected it, yes, or how it was?
No. Repeat, please.
I mean, when you diagnose it, you should discontinue carbamazepine, yes, because
Yes.
she has allergy. So after that, what you used in this patient?
Intravenous immunoglobulin and intravenous fluid that I provide my patient.
But what about with seizure?
Sorry.
I mean, so you use immunoglobulin E, yes, and then you discontinue carbamazepine, or you continue it?
Carbamazepine was withdrawn.
Withdraw.
Huh.
Okay, thank you.
Hello, Dr. Suman, can you? Hello.
Hi, madam. Yes, madam.
Yeah, actually, so I'd also like to ask Dr. Lolita's question. So how did you finally manage the epileptic attacks in that patient? Immunoglobulin was used for the Stephen Johnson syndrome, but the patient had a primary complaint of epileptic fits. So the patient needs some drug for anti-epileptic drugs. So which class or other alternative anti-epileptic drugs you started? That's what she wanted to know.
Alternative epileptic drug, that is phenytoin or anything else that
But phenytoin is also known to anyways. But I just want to know now, what are the investigations you did to confirm the epilepsy? Because there can be many causes of epilepsy. No? Did you do any investigation to know the cause? What type of epilepsy?
no.
Any
She was
secondary causes for epilepsy,
any secondary cause.
Yeah.
Genetical cause maybe happen.
Fine. Okay, thank you.
Thank you, madam.
Thank you, judges, and thank you, Suman. Now I request our next participant, Dr. Rini Harris, to present the case, and I request our next participant, Milena, to get ready with the case. So, Dr. Rini Harris, are you ready? Dr. Rini Harris? Okay. Milena, are you ready with the case?
Yes, I will try one more time, share the screen. Do you see the screen?
Yeah, it's visible, and your time starts now.
You see it, yes?
Yeah, you're audible, you're visible, and your time has started, okay? Just present your case.
Okay. So I would like to present a case report about a large meningioma in an extremely rare localization. It's a case report of a 40-year-old female patient. Meningiomas is a brain tumor originating in the arachnoid membrane, accounting for approximately 20% of all brain tumors. The cause of meningiomas are not well understood.
Clinical, if possible, can you full screen your slides, if possible?
Now it's okay?
Yeah, it's fine. Continue.
Okay. Clinical features of meningiomas reported in the literature are non-specific, include symptoms like headache or vision impairment, which can be related to the mass effect, and compression of the optic nerves. A 49-year-old female was urgently admitted to the neurosurgery ward for the treatment of tumor meningioma in the anterior fossa of the skull. Patient complained of the deterioration of vision, haze, in the right eye and partially in the left eye. Additionally, there were a weakness and pain in the whole body 2-3 times per day. No history of chronic disease or any other problems. Good general condition, Glasgow Coma Scale 15. A CT scan of the brain was performed before and after the intravenous administration of the contrast agent. An isodense tumor about 4,4 centimeter in diameter emerged from the level of the wedge ethmoid suture, undergoing homogeneous contrast enhancement, probably corresponding to the meningioma. It partially covered the genu of corpus callosum and clearly pressed against the frontal corners of the side chambers, narrowed brain furrows as expression of intracranial tightness. The main goal of this treatment is to complete removal of the tumor with a reconstruction of the tissue while maintaining the best possible functional status. The development of the skull-based surgery techniques allow for the same removal for the tumors, even in hard access localization. A month after CT scan, right frontotemporal craniotomy was performed with a passage over the frontal sinus, but without crossing it. After separating the tumor from the anterior fossa of the skull, clear osteophytosis was visualized. There was a large preoperative oedema, decrease after administration of mannitol and dexaven 8 mg. The next day, the control examination revealed a highly calcified residual lower part of the operated tumor, measuring approximately 3 to 1.5 centimeter in the right-left frontal lobe, and the level from the basal to the mid-ventricular layers, and the oedema area containing marginal petechia of the 3 centimeters in size was visualized. The left frontal lobe swelling zone associated with the operated tumor persists. There is also a small amount of extravasated blood in the reservoirs of the bones in the arterial hemispheric part. No disturbances at the central structures of the brain in the binocular axis was found. Intensive anti-oedema treatment was initiated. The patient, due to the RTS, was admitted to the ECU. Despite the treatment, the patient condition deteriorated rapidly, probably due to the increase of the edema cerebral. The patient developed features of the brainstem death at 5 a.m., 4 days after admission, cardiac arrest, and she died. Due to the clinically picture, no attempts were made to resuscitate. The husband objected to the autopsy of the patient. Discussion. Meningiomas are nowadays the most frequently diagnosed primary intracranial tumors. 1/3 of them spread of the base of the skull. The dominant neurosurgical manifestation of meningiomas in this localization are cranial nerve lesions, such as visual disturbance presented by our patient. The extracranial localization is associated with a significantly worse prognosis. The risk of failure is 2.7 times higher. The main goal of this treatment is to complete removal of the tumor with a reconstruction of the tissue while maintaining the best possible functional status. The development of skull-based surgery techniques allow the safe removal of tumors even in a hard access localization. Asphenoethmoidal sinus meningiomas are rare. Due to the tumor's significant size and localization, it was decided to perform frontal temporal craniotomy. It might seem that age, gender, and swelling before surgery are good prognostic factors, but do they always play a significant role? Thank you.
Thank you, Milena. Now I request our judges to continue with the Q&A round.
Thank you so much for your presentation, Milena. I want to ask you, so how I understand, CT scan was made in 16th of November, and then she was operated after 1 month. If it's like, okay, when it's so huge distance between CT scan and operation, if you don't need to make extra CT scan before operation?
The extra CT scan before operation was made, but the gap was so long because she was in the different hospital, and she has some problems with transport, and then she was located in the more specific hospital, like higher reference. That's why this takes so much time, unfortunately.
So unfortunately, you lost your patient to post-operative complications, but usually meningiomas are, they have a good biology and they are safe brain tumors. We do expect a longer survival in patients, at least with patient with grade 1 and grade 2 meningiomas. Of course, anaplastic meningiomas, they don't have a very good prognosis. So I just want to know, there are, suppose your patient, sometimes the location of these meningiomas, they are very difficult cases to operate. So can you suggest some other options? Nowadays you do have other options. If you cannot operate a patient who's say tumor or brain tumor, not only meningioma, any other brain tumor is in a critical position close to the brain stem, which makes the surgery dangerous. So, do you have an idea about other treatment options?
No, maybe trypanotomy or something like that.
No. We can use a radiation therapy. So stereotactic radiotherapy and all now, with all these techniques, with cyber knife and gamma knife, we can treat these tumors now. Especially we use this for such tumors. So these are the other options, and this is being used frequently. They are very safe. We give 3 to 4 shots of radiotherapy, which is focused at the tumor, and then we can treat the tumor safely.
But radiotherapy can increase the edema.
No. If you're doing stereotactic radiotherapy, it's very managed. And for that edema, treatment-related edema, you can always use a cover-up with dexamethasone and glycerol and all that. That is really safe, and because I'm a radiation oncologist now, that's why. Okay, thank you.
Thank you.
Yeah, before going to the next presentation, till now, how many presentations it was over?
So just a minute.
Hello?
So it's like six presentations. 6 to 7 presentations.
Okay, please maintain, like now, Niharika, you can leave the meeting now. Srinidhi will take over from now. Srinidhi, Sana will assist you. Like one can track the presentations. Like suppose if one participant is have any technical problem, immediately go to the next participant. So after the next participant, they can come back to the past participant who hasn't delivered the lecture due to technical problem. Give the chance to him. So like that, go and please check whether all participants are giving their presentation or not. Sana, you can track the timer 4 minutes. Srinidhi, you can introduce the participant. So I'm very I was very tired, and I will leave. I will keep the phone like laptop aside, and I will take some rest. So in case of any assistance, please give a missed call in WhatsApp so that I can get back. So
Okay,
I'm checking it all well, doing well in YouTube also. So you please manage the meeting for for today.
Okay, sir. Thank you.
Thank you, Tarun. Thank you, Tarun.
Yes, Srinidhi, continue. Like call next participant. You can see in group the name.
Okay, now next I would like to call Aishwarya Arkati to present a case and Mansa Pustke to get ready for the next presentation.
Only the 4 was just done. 5 se start hoga. The start will be from 5.
Dr. Rini Harris. Sorry for the disturbance. Now I would like to call Dr. Rini Harris to present her case and Shaurav Bhattacharjee to get ready for the next presentation.
Right. I think he's not there. You can go with Shuvro next.
Okay, then. I call Shaurav Bhattacharjee to present his case and Aishwarya Arkati to get ready for the next presentation.
Am I audible? So before the timer start, I want to say to the judges, Namaskar. I am Shubhra Bhattacharya from Medical College, Kolkata, and from the West Bengal. And I want to present a case. And please let me know my screen is visible or not. There's a whole screen visible option is there.
Yes, there's an option like that. We can see.
Yes, sir, your screen is visible now.
Okay, just give me 1 second.
Okay.
Okay, the screen is visible.
Yeah, you can continue.
Okay, I will start now.
Okay.
So my case is, according to the aggressive giant cell tumor over the calcaneum bone is a rare site. This is a disclaimer. Why I said that rare site? Because giant cell tumor is a benign bone tumor. It is aggressive in nature and high recurrence, but it's mainly developed in the long bones, but rarely affect the foot bone also. A 22 years old female present in our OPD with left ankle pain lasts for 9 to 10 months, and now the ankle joint movement is painful and restricted, and there is no history of trauma, no history of infection, and though no history of family history also, and no information of the medication. And you can see there is the OPD ticket of the patient. And when we go for the examination, we can found there is a prominent swelling and a tenderness over the left calcaneum. And when you go for the blood findings, you can clearly notice the normal level of calcium, urea, creatinine, and phosphorus also. And when you go for the X-ray, you can clearly notice there is a soap bubble-like appearance in the giant cell, in the calcaneum. And when you go for the MRI, we have just found that 4x2x2 hypodense osteolytic lesion is there. And when you go for the core biopsy, you can clearly notice there are some multiple giant cells present in the background of mononucleus tumor cells. And we all know the bone sheets just showing the fallen fragment like in the radiogram. The aneurysmal bone sheet showed the double density fluid in the CT scan. The condomixoid fibroma showed that denser pseudotuberculation. The chondroblastoma shown the chicken wire appearance. The brown tumor of the hyperthyroidism showed hyperparathyroidism shows the elevated calcium and the decreased phosphorus. But this finding is not matched with our case, so I can clearly say this is a case of the giant cell tumor. And after that, we go for the consent, informed consent. After saying the procedure and the probable risks of the surgery, and we go for the lip salvage surgery with the use of the modified sandwich method. After the incision, we use the 3 kVAR for the exposure of the flap. We use the cortical window making with the use of the electrical saw. After that, we scooping out the soft grayish well-defined lesions, and then we use the high-speed part for the extended curettage, and there is a whole huge cavity. And before the putting something, we wash with the hydrogen peroxide. After that, we use 2 calcaneus 2 and the bony cement, only bony cement for the just suppress the cavity. After that, we go for the alga denoted suture for the skin closure. And we use H2O2 for the microscopical damage of the residual cells and gelatinonic acid for formation of a good cell layer which prevents the recurrence. There is a post X-ray, you can see post-operation X-ray. And after the 15 days, the patient was discharged with the 2 weeks plaster operation, 1 month physiotherapy. And I can say the prognosis is good because after 6 weeks, the patient which can started gradually weight bearing. After 6 months, the patient can, there is no local recurrence, no wound issues, no swelling, and she was able to walk with partial weight bearing with axial crutches. And after 1 year and 2 years, now we can see that she was able to walk full weight bearing freely and ambulatory. There is the video, we can see that there is no, the gait is fully normal and there is no pain when she was walking nowadays. And now, I want to coming in the discussion. I want to say only 3% of the skeletal tumors present in the foot, and among the 1/3 present in the calcaneum, and giant cell tumor is very rare as per some studies also. But now this tumor has a tendency to become recurrent in the malignant transformation, and there's no specific symptoms, and maybe the most of the cases giant cell tumor will be go for the wide excision and the amputation also. And now in the recent days, temnizumab is used for the treatment of the giant cell tumor. And to conclude my study, I want to say the limb salvage surgery with the extended curettage with the use of the bony cement implementation with the calcaneus screw is a good or better option as than surgical amputations. This is my references, and I want to thank Dr. Soikot Shah, who is the backbone of this whole study and whole case study, and Med-Invade to give this platform to me and all judges and all them who are listening to me. Thank you so much.
Thank you, sir. Now I request our judges to proceed with Q&A session. Ma'am.
Thank you so much, Shahrukh, for your presentation. It was sort of full and amazing. And actually, I didn't have question. Maybe Dr. Richa will take it.
Thank you so much, ma'am.
Dr. Subro,
Yes,
what was the grade of your tumor?
Actually, ma'am, it is a short bone, so there is no campanigate. The campanigate is done for the long bone.
I want to know the grade of the tumor. After you did that white local excision, that tissue must have been sent for histopathological
Yes,
report.
ma'am. Yes, ma'am.
So what was the grade of the tumor? Because grade is something very important.
Yes, ma'am. That is, ma'am, grade is a grade 2 grade.
Grade 2.
Because there is no cortical implement is there, so there is a grade 2.
No, cortical impairment, what you're talking about, that is a radiological grading.
Yeah.
And
the FNAC rating.
Yeah.
FNAC rating is grade 2 also. And I have the FNAC report also.
You know, because GCT, giant cell tumor, that is a very, I think, that is something which can be very dangerous. If it is grade 1, it is a benign tumor, fine and good. But if it becomes grade 3, it behaves like a soft tissue sarcoma. That cases need to be. And how do you follow up this patient?
Ma'am, after 6 months, she come in our OPD. I'm in the medical college and I go to the OPD when she come. Actually, I have their phone number and I will meet and then I will
check. Dr. Subro, now when you are treating giant cell tumors, you have to be careful because these tumors, they may become malignant. If you look at the recent WHO classification, they have removed GCT from the benign category and have placed them in the intermediate category. So at least when you are treating or operating a GCT, please be more careful. You should call them for follow-up at least every 2 months for safety.
Now, ma'am, they started every 3 months, but because of the lockdown, the 6 months is there.
Okay, okay. And do you know any drug? Just an idea, any drug?
Yes, ma'am. Like Atotonex TH, we prescribe the patient. And
that is for
the pain. For the pain, yes.
Any drug which modifies, suppose that case is inoperable.
Like ma'am, just recently found the Denizumab, which is the rank ligand antagonist.
Yes, yes. So you can use that drug to downstage the tumor. In cases which otherwise would have required amputation, you can give a trial of Denosumab and then downstage the tumor. Okay, thank you.
Thank you so much, ma'am.
Thank you, judges, and thank you, sir. Now I request Aishwarya Khatti to present a case and Manas Pustake to get ready for the next presentation.
Am I audible and visible?
Yeah, you're audible, but your screen is not visible.
Yeah, I'm just sharing.
Yes. Before the presentation, ma'am, Richa ma'am, I think the session will go till 10:30 or 11. Like, if possible, please have a dinner by switching off video, and even the moderators also. Like, it's very tough to stay till 10 or 10:30. You can moderate by switching off your video, because I can understand till morning you are dealt with classes, so it's very exhausting. So please feel free and moderate the session.
Okay, sir. Now your screen is visible and you can proceed now.
Okay. A very good evening to one and all present here. I'm Aishwarya Khatti from Ramaya Medical College. I'll be presenting a case on lower lobe cavity of the lung caused by Klebsiella in a post-COVID patient. And I'm doing this under the guidance of Dr. Ashwin Kulkarni. So this is a male patient who's aged 66 years, who was admitted to our hospital on 3rd of June 2021. He came with complaints of cough, breathlessness, and generalized body ache since 5 days. It was not progressive in nature, and the cough was not associated with sputum. He also developed breathlessness, which worsened on the day of the admission, with the saturation being 88%. He was diagnosed previously with COVID-19 on 5th of May 2021 and was given oxygen supplementation and was under intensive care for the same, and was later discharged on 25th of May. Past history, he is a type 2 diabetes mellitus patient and also has hypertension since 2007, also has hypothyroidism, and underwent a procedure for ischemic heart disease in 2009. His general physical examination was normal. Systemic examination, when doing the respiratory system examination, cavernous breath sounds were heard over the right intra-axillary and intramammary areas. Investigations, his HbA1c was 9.8%. Gene expert was negative for Mycobacterium tuberculosis. KOH mount was negative for fungal elements. And sputum culture and sensitivity showed Klebsiella pneumonia, which was sensitive to colistin. The chest X-ray and HRCT revealed a cavity in the right lower lobe, which was basically a round to oval lucency with a thick wall. So the diagnosis is right lower lobe necrotizing pneumonia with a large cavity. So the treatment, he was initially started on piperacillin and tazobactam, and once the report came in, colistin was given. His regular medications were continued, and along with insulin for controlling his blood glucose levels. Differential diagnosis, cavity secondary to pulmonary tuberculosis, and also COVID sometimes, very rarely, can cause cavitation by itself. Prognosis, secondary infections in COVID are known to happen. Cases with Klebsiella pneumonia are very difficult to treat because hemoptysis is rapid with very fatal with them because of rupture of bronchial veins by the organism. The patient also had other health conditions which makes the prognosis poor. The follow-up, he showed improvement after 5 days, and this is a repeat X-ray which shows resolution, and he wanted to return to his native, so he was advised to continue colistin for 7 more days. So discussion, cavity lung lesions are usually related to mycobacterial, parasitic, fungal, and autoimmune or neoplastic etiologies. The typical CT imaging in COVID-19 includes ground glass and consolidated pulmonary opacities, which are primarily in the lower lobes. Lung cavitation is again very uncommon due to COVID-19. There are very few case reports published. Although the exact mechanism is not known, it is associated with diffuse alveolar damage, intraalveolar hemorrhage, and necrosis of the parenchymal cells. So secondary infections have been reported to occur in about 15% of patients, and bacterial co-infection along with COVID-19 in admitted patients is reported to be around 3.1 to 3.5. Out of these, the most commonly isolated organisms are gram-negative bacteria, most common being Klebsiella. So Klebsiella basically affects the lower lobes most commonly, but in this case, it is a presentation in the lower lobe. And some of the factors that predispose are admission to an intensive care ward, invasive device use, as well as immunocompromise, especially in diabetics, which this patient is. So the pathogenesis in this case is because the organism can bind to the host cells and it can provide self-protection against the human immune system. And recently there has been a raise in the incidence for resistance to antibiotics to the carbapenem group, which are the so-called drugs of last resort used in these severe infections caused by gram-negative bacilli. So the conclusion, the COVID-19 disease spectrum continues to evolve and all the complications are not entirely known. Cavity lesions, though rare in COVID, can cause life-threatening complications, especially hemoptysis. So a thorough workup, including imaging, is imperative to diagnose and follow patients early during the active infection as well as convalescence. These are my references. Thank you.
Thank you, ma'am. Now I request our judges to proceed with Q&A session.
Thank you so much for your clinical presentation. This is a patient, is post-COVID patient, yes. And what about he was before he has this cavity? He was hospitalized, or he had his treatment from the COVID? He was hospitalized.
He was hospitalized under intensive care for around.
And he was like with IV. Oh, was ventilator? On ventilator?
No, he was just given oxygen supplementation, but because he had many other comorbidities, he was also under intensive care.
Okay, thank you.
Thank you.
Okay, so that was Dr. Lolita's domain. No questions. Thank you.
Thank you. Thank you so much.
Thank you, judges, and thank you, ma'am. Now I request Manas Pustake to present his case and Bhavya Bhagwan to get ready for the next presentation.
Okay, am I audible?
Yeah, you're audible.
Is my screen visible?
1 second, sir. No, sir, can you try doing it again?
Is it visible now?
Yeah, now it is visible. You can proceed.
My name is Manas Pustak and the title of my case is eosinophilic granulomatosis with polyangiitis masquerading as primary pulmonary eosinophilia. The case is original work of us. Informed consent was taken from the patient. Introduction. Eosinophilic granulomatosis with polyangiitis or Crux-Strauss syndrome is one of the rare diseases. A poorly controlled, prolonged duration adult onset asthma with peripheral eosinophilia and raised serum total IgE should arouse the suspicion of chronic eosinophilic pneumonia, hypereosinophilic syndrome, and acute bronchopulmonary aspergillosis (EGPA) in clinician mind. Among these diseases, vasculitic symptoms are specific for EGPA, but they can be delayed by as much as 10 years. Case presentation. A 45-year-old gentleman, a worker in a cement factory for the past 28 years, presented to us with a history of adult onset controlled asthma of 5 months duration. In 2016, he had visited us with acute worsening of dry cough and shortness of breath of 5 days with a background history of 5 months duration, insidious onset, progressive breathlessness associated with wheezing and dry cough. He was managed as a case of acute exacerbation of asthma and received antibiotics, a short course of oral steroids along with inhaled steroids. Since then, he had been on regular outpatient follow-up and had moderate persistent asthma with nocturnal awakening once per week, despite adequate therapy escalation and good medication adherence. During routine outpatient workup, he was found to have persistent eosinophilia and persistent increased total serum IgE. 3 years later, in the year 2019, he was hospitalized again for similar complaints. He had very high absolute eosinophilic count and an elevated serum Ig on routine laboratory workup. His HRCT of thorax showed multiple peribronchoscopal T-inward nodules and ground glass opacities in both the lung fields. He then subsequently required 3 hospitalizations for exacerbation over the next year, which were managed conservatively. Finally, in August 2020, the patient was admitted with a month-old history of purpuric rash and bullous eruption involving both lower limbs and intense burning sensation, for which he had tried herbal decoctions at home, after which the bullae ruptured and spontaneously leaving multiple superficial ulcers. We can see that image here in the right side of the screen. On investigation, P-ANCA by indirect immunofluorescence was positive. Nerve conduction study shows predominantly axonal sensory motor polyneuropathy affecting upper limbs more than lower limbs, and skin biopsy from the edge of that ulcer showed leucoplastic vasculitis with eosinophilic infiltration in the walls of medium-sized vessels. Figure 2, 3, and 4 showing the biopsy results. Differential diagnosis. In 2016, initial differential diagnoses were considered as occupational asthma secondary to cement dust, allergic asthma, Loeffler's syndrome, drugs and toxin-related eosinophilic pulmonary infiltration, pulmonary tuberculosis, sarcoidosis, hypersensitive pneumonitis, allergic bronchopulmonary aspergillosis. Finally, during his most recent visit to us, he emerged with signs of vasculitis with skin and peripheral nerve involvement, allowing us to make the diagnosis of EGPA, which was later validated with skin biopsy. Considering these presenting attributes as well as patient financial constraint, the patient was eventually diagnosed with EGPA. Treatment and outcome. He was administered methylprednisolone pulse therapy 1 gram once a day for 3 days and cyclophosphamide 15 mg per kg, 3 doses, each dose once fortnightly, then 4 doses a month were advised. Cocker splint and physiotherapy were provided for wisdom. He was being followed up monthly. At 6-month follow-up, improvement in the hand grip was noticed. With his right hand, he could do everything after 6 months. Discussion. EGPA usually progresses through 3 stages, namely prodromal, eosinophilic, and vasculitis. However, these phases are not easy to tell apart. The appearance of vasculitic symptoms can be delayed by as much as 10 years after the onset of pulmonary symptoms. Surprisingly, several cases have indicated improved asthma control after the onset of vasculitis. Fortunately, our patient had the same encounter. These are my references. Thank you.
Thank you, sir. Now I request our judges to proceed with Q&A session.
Thank you so much, Manas, for your presentation. I have one question. So after you treat your patient, he was follow-up, he was okay. What's the chance that he can have again this problem?
So which problem?
Like this disease which he has with eosinophilic syndrome.
Sorry.
Can it be repeated? You know, like so he has this complaint with the eosinophil, and can it be returned?
Sorry, I'm not getting you.
Okay, maybe I'm not so good, like there's some connection. Maybe Dr. Richa will help me.
Sorry.
Can you hear me, Manas?
Yeah.
Dr. Lolita, she wanted to know now what are the chances of remission and exacerbations of the symptoms in this patient. So this is an autoimmune disease, right?
Yeah.
So the patient will go into remission and then they will have a recurrence.
No, as far as literature is concerned, there weren't there were very few cases of remission, recurrence actually. There wasn't like what I have done in literature.
So you're saying this is a curable disease. You give medicine and the patient will be cured.
Yeah. No, not curable, but controllable.
Okay.
As in our case, we experienced full recovery, almost full recovery within 6 months of treatment with methylprednisolone and cyclophosphamide.
And then did you follow up the patient or?
Yeah. We followed up the patient for each month for next 6 months after initiating the therapy. After being
how do you follow up? Do you suggest any investigations or blood test or anything? Or you just
no, just the clinical follow-up. Just the clinical follow-up.
A clinical follow-up.
Yeah.
Okay. Dr. Lolita, is that what you wanted to know?
So thank you so much.
Okay, fine. Thank you, Manas.
Thank you so much.
Thank you, sir, and thank you, judges. Now I request Bhavya to present a case and Shakti Jnanvel to get ready for the next presentation.
Thank you. Just give me a moment. Am I audible?
Yeah, you're audible.
Thank you.
Manas sir, can you please stop your screen sharing?
Yeah.
Okay, thank you. Bhavya ma'am, are you there?
Yeah, just a minute. Actually, I'm not able to share my screen.
Okay, okay.
Is it possible if you could share my case?
Okay, ma'am. If there is any network issue, you can send it to the WhatsApp group, which you were there in that. Now I'll let the other one to present the case. Then after that, I'll share your case. Then you can present it. Is it okay?
Okay, I think that would work.
Okay, then. Please share your case to the WhatsApp group.
Sure, I'll do it. Thank you, and
Okay.
I'm sorry for the inconvenience.
It's okay, ma'am. I request Shakti Gyanwil to present his case and Shreyashi Bharatwaj to get ready for the next presentation.
Good evening to one and all present here. Give me a minute. I'll share my screen right now.
Okay, sir.
Okay. Can you see the screen? Is it visible?
Yeah, it is visible. You can proceed.
Okay. Good evening to one and all present here. I'm here to present a case on epilepsy and DMD, a case for epilepsy and DMD. This is an original case being presented by myself, Shakti Gyanwil, a fourth year MBBS student at Mahadevappa Rampuri Medical College, Kalaburgi. And the patient details are: it was male. The patient was a male, 16-year-old, and address Kalaburgi. The chief complaints was one episode of convulsion. So, history of present illness: the mother gives history of child having one episode of convulsion at home at around 1 p.m. with involuntary jerky movements involving only the upper limbs, with uprolling of eyeballs and frothing lasting for a few minutes and later regaining consciousness. It was associated with bladder incontinence, no history of fever, rash, dark colored urine, hurried beds, falls, or trauma. Past history: mother also gives a history of similar episode of convulsion on the postnatal day 3, for which he was admitted to the hospital and put on a ventilator for 15 days and later discharged with anti-epileptic medication, which was continued for 3 years. Patient developed difficulty in walking at 8 years of age, prior to which he presented with Gover's maneuver. Birth history: pregnancy was non-booked. The patient was delivered at home by an untrained dive by normal vaginal delivery. The baby suffered from birth asphyxia. Immunization history: BCG scar was absent. No record of any immunization. Family history: a younger male sibling has a similar history of developmental delay along with regression of attained milestones after 4 years of age, with history of fever after rash over abdomen and thorax, thereafter being unable to walk. Elder female sibling of 20 years having normal development. History: marriage history was history of non-consanguineous marriage, with them being third-degree far relatives. Examination: the pulse was 140 bpm, beats per minute, height was 132 centimeters. Blood pressure was 90 over 80 mm of Hg, weight was just 20 kgs, and respiratory rate was 20. The general physical examination: head had hair evenly distributed. Eyes: left eye was normal. Right eye showed coloboma varus. Nose and ears showed no discharge. Mouth showed crowding of teeth and poor oral hygiene. Neck had no cervical lymphadenopathy, but there was a presence of scar mark. Thorax showed pectus excavatum. Abdomen: no distension. Genitalia: male with edema of profuse was seen. Upper limb shows muscle wasting. Lower limb showed bilateral calf muscle pseudohypertrophy. CNS examination: patient is conscious, oriented to time, place, or person. Good attention and concentration was observed. Immediate short-term and long-term memory were all intact. Insight was present. Patient had a good rapport. Patient was bedridden, poorly dressed, and had poor personal hygiene. Cranial nerve examination: all cranial nerves showed normal functioning. Reflexes: superficial reflex, abdominal reflex was absent. Plantar reflex, flexion of the great and other toes were able to be observed. Deep tendon reflex, bicep reflex couldn't be elicited. Knee jerk couldn't be elicited. Stance and gait: patient can't stand or walk. He's currently bedridden and bound to the wheelchair. Involuntary movement.
You are reaching your time limit. Just speed it up.
Okay. Motor system: there was a lot of muscle wasting seen. The tone of the muscle was reduced. Hypertonia was seen in all cases. Power was reduced. And then no signs of meningeal irritation was seen. CVS showed normal reading with precordial bulge in the fifth intercordial space. Intercostal space, sorry. Respiratory system was normal. Abdominal examination was normal. Then MRI brain showed dilatation of parieto-occipital regions and features of old hypoxic ischemic encephalopathy. CPK total was 902 international units per liter, and differential diagnosis: Becker's muscular dystrophy, limb girdle muscular dystrophy. The diagnosis is motor system involvement, which was probably Duchenne muscular dystrophy. Positive GOVA sign was seen few years ago when the child was ambulatory. Treatment was the patient was treated was stabilized with IV fluids and then treated with prednisone. Patient was unwilling for follow-up later on. The prognosis: Duchenne muscular dystrophy has a poor prognosis, but there is optimism that the disease may benefit from novel therapies that either replace the defective gene or missing protein. It's an X-linked recessive disorder. Serum CK levels are inevitably elevated in this. The most common gene mutation is deletion of the dystrophin gene present on the short arm of the X chromosome at XP21. Conclusion: I would like to
Sir,
conclude.
you're short of time. Can you please conclude it quickly?
Okay, yeah. Conclusion: I would like to conclude by saying that much more importance should be given to genetic counseling and amniocentesis. Exon skipping drugs have been found out, such as eteplirsen and Vyondys 53, but these are not a cure. Basically, a new gene therapy has been developed too, called PF06939926. But the problem is we have to focus more on genetic counseling so that we can prevent occurrence of the disease. As we say, prevention is better than cure. Thank you. References. And thank you.
Thank you, sir. Now I request our judges to proceed with Q&A session.
Thank you so much for your presentation. So you said this patient also has siblings with the same symptoms.
Yes.
If the siblings was older or younger, and if you know what was with his siblings.
I couldn't quite get you. The sibling was a younger one, basically. So the younger sibling could have been saved by genetic counseling or amniocentesis. So that's what I wanted to conclude by. That was my conclusion.
Thank you so much.
Thank you.
Dr. Richa, can you read? We can't hear you, Dr. Richa. You haven't unmuted yourself.
I think I was stuck. Okay, so Shakti, so that was a rare case, and just a general question. I mean, this is not my specialty. So how often you do genetic counseling for such patients? I mean, practically.
Practically, genetic counseling is usually done when it's close relatives or when there's consanguineous marriage. We in community departments and all, we talk about people to undergo genetic counseling now. But as this was a non-consanguineous marriage, the rarity is much lesser. I believe that every marriage should actually have a genetic counseling before, so we can at least reduce the incidence of cases as such.
Okay, thank you.
Thank you.
Thank you, judges, and thank you, sir. Now I request Shreyanshi Bharadwaj to present her case and Bhavya Pahwan to get ready for the next presentation.
Hello.
Yeah, yes, ma'am.
Yeah, I'm doing the screen sharing. Give me a minute.
Okay. Yes, sir.
Yeah, please look over the participants. Like, please allow. I have made you co-host to have option to allow the participants. You can see. We'll see the notification. Please allow. Please look over that also.
Okay, sir. Ma'am, are you there?
Yes. Hello, please carry on with the next case as I try to set up.
Okay. Now I'll present the case of Bhavya Pahwan, ma'am.
Thank
Shall
you.
I proceed?
Sure, yes.
1 second.
Actually, I just, figured out.
Is it visible?
Actually, I'm really sorry for the inconvenience. Like, my screen started, working. So is it okay if I present, because like this is a bit short, like I couldn't view it. So can I present myself?
Yes, ma'am. Okay, you can continue.
Thank you. And I'm really sorry, guys, for the inconvenience.
It's okay, ma'am.
Is it visible?
Like, is it visible? I'm asking you, ma'am.
We're still looking at Srinidhi's screen.
Is my screen visible?
No, Mahavir, we're still looking at Srinidhi's screen.
Okay.
1 second.
We are looking at your screen now.
Okay, ma'am, it is visible.
Okay. Let me know when I can start.
Yeah, you can start it now, ma'am.
Okay, thank you. So good evening, everyone. I'm Bhavya Pahava, a second-year medical student at University College of Medical Sciences, New Delhi. My case report today is prolactinoma and pregnancy. So a little bit introduction what prolactinoma exactly is. Prolactinoma is a benign tumor of anterior pituitary whose incidence is 0.4% in general population. It can cause menstrual irregularities because of hormonal changes, infertility, as well as complications during pregnancy and postpartum period. Over 90% patients with prolactinoma can, after medical treatment, can get back to their normal lives. However, during pregnancy, there is an increase in the risk of neurological sequelae that ranges from 1.6 to 5%. Serial monitoring of the serum prolactin and regular antenatal surveillance results in an uneventful pregnancy, which is quite rare. Well, the case report says that
Ma'am, there might be some technical issues. You're not audible, ma'am.
Srinidhi, we can hear her.
Okay, ma'am.
A case report of 30-year-old unmarried female with history of amenorrhea since 2 years sought consultation gynae OPD with care of blurred vision, headache, and vomiting. Certain investigations were done which revealed a normal T3, T4, TSH level. However, her serum prolactin was extensively high. The skull radiograph showed a microadenoma in the pituitary cellular flow of 10 into 8 mm of measurements on the right side. Endocrinologist's opinion was taken. She was put on cabergoline 0.5 mg once a week. After initiating the treatment, her menstrual cycles regulated, and then she lost to follow for a period of 1 year. Again, after 1 year, she got married and presents with history of missed periods. Her UPT was positive. In first trimester of pregnancy, her USG was normal and all the relevant antenatal investigations done, they were normal. She was regularly taking the prescribed medicine that was cabergoline. The second trimester, her visits were regular and her level 2 anomaly scan was normal. Patient stopped the medication for 5 to 8 weeks on her own and presented in the gynae OPD at 25th week of gestation with care of dizziness, blurred vision, vomiting, severe headache, and lower limb weakness. Urgent MRI was done. Patient was hospitalized and urgent endocrinologist opinion was taken, where the relevant blood investigations done were prolactin of 580 nanograms per ml. She was again put on cabergoline and was forbidden to take that per week, and prednisolone 10 milligrams per day, conservatively managed and discharged satisfactorily. Well, the MRI brain again showed a microadenoma of size, though it was reduced. It was 10 into 7 with area of hemorrhage in the anterior pituitary on the right side. Pituitary stalk was slightly displaced towards the left side. Third trimester was normal, regular antenatal checking. Rest of the antenatal period was quite uneventful, and serum prolactin level was within normal limits. Discussion: prolactinoma during pregnancy can cause complications, but in our case, the patient was absolutely fine until 6 weeks of pregnancy. 6 months, I'm sorry. Although after that, she developed complications due to hemorrhage of the pituitary gland. There is an increase in the tumor size. During pregnancy, the results are increased estrogen. However, in our case, instead of increasing, the adenoma decreased by 1 mm. Owing to the neurological symptom, the patient is put on steroid that was prednisolone 10 milligram per day. However, which is known to cause fetal effects. However, neither the patient delivered a healthy baby, and our patient was given that's cabergoline throughout the pregnancy with a gap of 5 to 8 weeks, which led to complications. So even patients with microadenoma, they could be properly counseled and closely monitored to have a good maternal and fetal outcome. I'd just like to add in here that the picture that is this one, which was taken from Netters, and that was one reference I'd like to give. Thank you.
Thank you, ma'am. Now I request our judges to proceed with Q&A session.
Thank you so much for your presentation. I don't have any question.
Yeah, Mahavir, I have a question. Your patient had a microadenoma. The size was very small, 10 into 8 mm. But then your patient had, blurring of vision, headache. These are usually pressure symptoms which we see in patient with a macroadenoma.
Yes, ma'am.
So these microadenomas usually, when they are, most of the cases, they do not cause any symptom, but if they are functional, they are secreting hormones, they can cause the symptoms. But I couldn't understand the cause of blurring of vision and headache in your patient. The size was very small. So what was the site of the microadenoma?
Ma'am, it was in the ciliary floor exactly above the optic chiasma.
Okay.
Like it was impinging on it that was leading to the blurred vision. So like the optic chiasma, it was exactly above it.
Okay, but usually we don't see, pressure
Yes, ma'am.
microadenoma. Another question, the prolactin level was very high. So your patient didn't have any complaint of, discharge from nipple or something like that?
Ma'am, there were like, initially when she came, she was like, the periods, like missed periods, and there were certain discharge, but it wasn't that high. So like, these were, I might have missed it to add that one. So yes, there was discharge. I mean, that's why, that led us to think that why that could be prolactinoma.
Usually these patients now, they present with mastalgia and, engorgement of breast and milk-like discharge from the nipples. So these are very common symptoms. Okay, thank you.
Thank you, ma'am.
Thank you, judges, and thank you, ma'am. Shreyashi Bharadwaj, are you ready to present your case? Shreyashi, ma'am, are you there? Okay, moving on. Jessie Apurva, are you there?
Yes. Can I start my?
Yes, ma'am, you can present.
I'm sorry to interrupt. Can I send it to you on WhatsApp?
Yes, ma'am, you can send it on the WhatsApp group.
Okay, thank you.
Okay, ma'am. Next, I request Vishal Raja to get ready for presenting his case. Apurva, ma'am, you can continue.
Yeah. Is my screen visible?
Yes, ma'am, your screen is visible.
Okay. Good evening, everyone. I'm Jessie Apurva and I'm presenting a case of paraparesis due to compressive myelopathy secondary to POTS 6. The following case is in original and I have written the case report. A 48-year female patient resident of Bashirabad and housewife by occupation came to the casualty with the chief complaints of lower back pain since 3 months, tingling and numbness of lower limb since 3 months, weakness of lower limb since 1 month, and incontinence of urine and stool since 3 days. History of presenting illness: patient was apparently asymptomatic 3 months back, then developed backache in the lumbar region radiating to both lower limbs, aggravated in mornings, evenings with movement, and relieved by rest. Insidious in onset, gradual in progression, dull aching pain in the beginning, progressed to severe pain later, associated with tingling and numbness. Weakness of lower limb since 1 month, difficulty in getting up from supine position, raising arms above shoulders, difficulty in walking even with support since 1 month, bedridden, unable to roll over the bed since 1 week. No history of evening rise of temperature, loss of appetite, loss of weight, chest pain, sputum production, local trauma or mass in the back. Multiple masses were found in the region of the left axilla, the largest of 6 into 5 centimeters. Insidious onset, gradual progression, non-tender, noticed 2 months ago. A mass of 4.5 into 3.7 mm was found in the left supraclavicular region. Past history: no history of similar complaints in the past, no history of hypertension, diabetes, tuberculosis, or epilepsy. Family history: patient's father had an episode of tuberculosis 5 years ago and was treated accordingly. No other significant medical history. Personal history: mixed diet, normal appetite, adequate sleep, bowel and bladder were catheterized, not a known allergic to any drugs or eatables. General examination: patient was conscious, coherent, and cooperative, moderately built and nourished. All the vitals such as temperature, pulse, blood pressure, and respiratory rate were normal. Pallor and pedal edema were present. Icterus, cyanosis, clubbing, and lymphadenopathy were absent. Coming to systemic examination, CNS motor examination: bulk of the muscles was bilaterally equal. Tone spasticity is found in both the lower limbs. Hypotonia, power, upper limb 5 by 5 and 5 by 5. Lower limb reduced power of grade 2 by 5 is seen in both right and left lower limbs. Coming to sensory examination, temperature, pain, touch, vibration were bilaterally equal and decreased from the knees. Reflexes, biceps, triceps were positive in both the upper limbs. Knee and ankle reflexes were absent and plantar reflex was decreased in both the lower limbs. Local examination of spine on inspection, normal curvature, no evidence of any abscess, mass or gibbous is noticed. Palpation, no abnormality, mass or abscess felt, no tenderness. Local examination, inspection, multiple swellings in the regions of left axial and supraclavicular regions, surface is smooth, skin of the swellings normal, irregular borders and no discharge. On palpation, inspective findings were confirmed, swelling of firm in consistency and palpable lymph nodes. CVS examination, S1 S2 heard, no murmurs, respiratory examination, bilateral airway entry positive, normal vesicular breath sounds, and no adventitious sounds are heard. Per abdominal examination, soft, non-tender, no organomegaly. Investigations, general investigations, hemoglobin was found to be less, RBC hypochromic microcytes, WBC neutrophilic leukocytosis was seen, ESR was raised and is found to be of 120 mm. MRI of lumbar spine showed destruction of L2, L3, L4, L5 vertebra, suggestive of pot spine with left psoas abscess and involvement on pre- and paravertebral soft tissue. Lumbar vertebral wasting is noticed. CT spine showed moderate hydrouteronephrosis. On CT chest, a breast mass of size 6 into 5 centimeters in the left axillary tail of Spence and left necrotic axillary supraclavicular lymph node enlargement was noticed. On FNAC, ductal carcinoma in situ of the left breast was noticed. This is the picture of the patient, and the attitude of ease was of hip flexion and abduction. Coming to final diagnosis is paraparesis secondary to compressive myelopathy due to POTS disease. Treatment, patient was kept under IV fluids and vital monitoring. Tablet Benadryl and blood transfusions were done to manage anemia.
Ma'am, you are running out of time. Can you please conclude it quickly?
Okay, IV antibiotics was given. Category 1 anti-tubercular regimen was prescribed. Patient was planned for chemotherapy and radiotherapy. Differential diagnosis, paraparesis can be secondary to compressive myelopathy due to pyogenic spondylitis, osteoporosis, bone tumors, metastasis, and myopathy. Follow-up, patient is still under treatment and the prognosis was poor. Thank you.
Thank you, ma'am. Now I request our judges to proceed with Q&A session. Judges?
Yeah, Jesse.
Yes, ma'am.
Yes, ma'am.
Yeah, I'm a bit confused. So what was the diagnosis of your patient? Was it a tuberculous lymphadenitis or was it a malignancy? Because I didn't think an FNA or a biopsy was done. There were big palpable lymph nodes, a big lump in the breast.
Yeah, it was that. On FNS, it was found to be DCIS, ma'am, with lymph node metastasis.
That was from the breast, na?
Yes,
Ductal
ma'am.
carcinoma in situ, they don't metastasize unless and until it's an invasive ductal carcinoma. It won't have lymph nodes. But then the final diagnosis, as I could see in your slide, it was something pot spine with paraparesis. Yeah. Why was the treatment planned for chemotherapy and radiotherapy? If it's tuberculosis, your patient has a generalized lymphadenopathy. But at no time I could see, you should have gone for a biopsy because that would differentiate. Either if it's tuberculosis, the treatment is something different. If it's malignancy, the treatment is something different.
It was actually a case of tuberculosis with pot spine, ma'am, but it was also coexistent with DCIS.
But DCIS is nothing, that is carcinoma in situ. We don't prescribe chemotherapy and radiotherapy for that. Ideally, if it's a big mass, 6 into 5 centimeter, you need to do a core needle biopsy. And if it comes out to be an invasive ductal carcinoma, then you could assume this to be a case of a CA breast with multiple spinal metastasis.
The patient is still undergoing treatment, ma'am. So,
but you need to establish the diagnosis now. There are two different things. The treatment will be entirely different. It's a cancer. The treatment is chemo and radiation because it is a stage 4 disease. If we assume that the bony lesions were because of metastasis, if it's a pot spine, the treatment is entirely different.
For pot spine, ATT was started, ma'am.
Mm-hmm. They can coexist, but then to establish, cancer, you need a biopsy. And a patient with DCIS, that is carcinoma in situ, that is a pre-invasive stage. So we don't use a chemotherapy or radiotherapy for those patients. Okay, thank you.
Thank you, ma'am.
Yes.
Yeah, thank you, ma'am. Lolita, ma'am.
Thank you so much for the presentation. I don't have any question.
Thank you.
Okay. Thank you, ma'am, and thank you, Apurva, ma'am.
Thank you.
Now I request Vishal Raja to present his case and Ayan Paricha to get ready for the next presentation.
Did you receive my presentation on WhatsApp?
No, ma'am, I didn't get it till now. I'll inform you when I get it.
Okay, thank you.
Vishal sir, are you there?
Yeah, I'm audible.
Yeah, you're audible, sir.
Is this visible?
Yes, sir, it is visible.
Okay, good evening,
Yes, sir,
judges.
sir.
Good evening, everybody. Okay, I'm P. Vishal Raja from Indira Gandhi Medical College and Research Institute, Puducherry. Moving on to the case presentation. This is a 10-year-old girl from Puducherry came with chief complaints of progressive weakness for 6 days. History of presenting illness. She has no past medical history, was in camping, like Kozak. 6 days prior to admission, started to feel some tingling in both feet. After 1 to 2 days, started to have the same tingling in both hands and around the mouth. This tingling sensation never ascended or expanded, but is still present after 6 days. Almost 3 days prior to admission, started to feel weak, especially with tasks like standing up from a sitting position. Known history of fever, cough, diarrhea, rash, known tick bites, sick contact, and recent vaccination. And she has no mild abdomen pain. Was seen by PCP before developing weakness, and CBC, CMP, ESR, CRP were reported normal. No past medical history, no the growth and development were normal, no medications were taken, no history of family history, and she was immunized up to date, nothing recent, and no history of fever, headaches, no vision difficulties, no weight change, and no constipation. Moving on to the physical examination, the temperature was 36.8 and respiratory rate for 21 and the BP 134 by 88, partial pressure of oxygen is 98%, and she was well developed, well nourished, 10 years old. Right-handed girl communicating well, cooperating with exam. She's atraumatic, normocephalic, eyes without swelling, redness or discharge, ears without drainage, nails are patent, mouth with mucous membrane moist, pink without lesions. Neck was supple, lung clear on auscultation with good air movement bilaterally. S1 ST without murmurs. Abdomen soft, non-tender and non-distended. Moving on to the musculoskeletal, active range of movements and passive range of movements without limitations in all major joints. No contractions noted. Very slight tenderness on spine, palpation in the thoracic area. No rashes present on the skin. Moving on to the neurological examination, mental status of the patient was awake, alert, fully oriented, and cooperative with examination. Speech is clear, without aphasia, dysarthria. CNS examination, visual acuity field intact. People equal, round, reactive to light, extraocular muscles, masseter muscles, strength preserved, bilaterally and symmetric, pain sensation intact in all 3 divisions. And no facial symmetry, but profound weakness upper and lower face bilaterally, and she cannot whistle, cannot pucker, no featured expressions. Hearing grossly intact, voice is intact, and no symmetry of the soft palate. Shoulder shut, present bilaterally and symmetric. Articulation is clear and intact. A visible belt phenomenon, articulated circulation strength is 2. Moving into the motor biceps, 4 bilateral triceps, 4 wrist flexion is 4 plus, wrist extension 4 bilaterally, hip flexion is 2 bilateral, knee extension 4 plus 2, 5 bilateral, knee flexion 4 bilateral, ankle dorsiflexion 4 bilateral, plantar flexion is 5. Reflexes, a deep tendon reflexes biceps 2 on right, 0 to 1 on left, triceps 2, brachioradial 0, knee ankle, toes 0. Sensory examination, grossly intact for soft touch, vibration, proprioception is intact. Coordination in gait, normal finger to nose test and heel to shin. White stance and gait, difficulty raising from sitting position. Moving into the lab investigation, CBC, WBC count is 9.49, hemoglobin is 14.1, platelets 326, and ESR is 10, and biophysical profile, sodium 137, potassium 4.5, calcium 8.9, glucose 129, blood urine nitrogen is 8, and creatine is 0.8. So the final diagnosis is childhood Guillain-Barré syndrome. We can see lesions in spinal cord and also in peripheral neuropathy. Spinal cord lesions such as...
Sir, you're running out of the time. Please conclude it quickly.
Yes, wait. Acute transverse myelitis, epidural abscess tumors, and poliomyelitis, Hopkins syndrome, vascular malformations, and cord infection, fibrocartilaginous embolism, and acute disseminated endocarditis. These are the peripheral neuropathies. These can be toxic infection, inborn errors of metabolism, critical illnesses, neurovascular junction disorders. These are the imaging shown in this GBS. Moving to the history, epidemiology, US incidence, international dates, US 6, male to female ratio is 1 to 1 to 7 point age, 2 months to 95 years, and childhood GBS average age is 40 years. Mostly they present with weakness, And mild A reflex can be seen. Paresthesia often precede the onset of the weakness and autonomic dysfunction. 2/3 of the patient, most common is sinus tachycardia. Spitting dysfunction can be seen. Lower back or hip pain is most common. Speech disturbances rarely occur in the case of GBS. The most common symptom at onset in periodic GBS
Sir,
is
it's 5 minutes. I request you to conclude it.
Just 1 minute. Will you give 1 minute, please? Hello.
No, sir, I can't. It's already 5 minutes.
Okay, what causes and triggers GBS immune responses? First thing, and Clostridium gingivae in children association GBS, and the vaccination, flu, malignancies, pregnancies, and hypophosphatemia. And this is a pathophysiology, and we have to work up like ESR, albuminocytologic dissociation. Some of oligostandard plants are mainly phase protein antibodies, especially for variants. Critically ill patients with AIDS develop SIDH. Some liver enzymes are elevated, and autonomic function tests have to be clearly. A treatment, plasmapheresis treatment is given. AVAG alternative treatment. Prognosis, good prognosis in children during the early stage, increasing severity in mean disability scores. 10% may have relapse in 1 to 6 after completing immunological therapy. Mortality is 2 to 6%. And these are the references. Thank you.
Thank you, sir. Now I request our judges to proceed with Q&A session.
Thank you so much for your presentation.
Thank you, ma'am.
Can you repeat for me what about the follow-up of your patient?
Follow-up, we have to give special blood treatments, ma'am, like a plasma exchange and immunoglobulin therapy. So in order to relieve the symptoms, and physiotherapy is also required, ma'am. Supportive care like mechanical ventilations and intubations can also be given. Physical therapies can also be given for the follow-up of the patient. It is good prognosis in children, ma'am.
Thank you so much.
Okay, thank you.
Okay, so what drugs you used in your patient and how did that patient respond to treatment? Your patient, in this case.
Ma'am, sorry, I didn't get you, ma'am.
What was the response to treatment in your patient, this case?
Responded well, ma'am. With it, she was given plasma exchange and immunoglobulin, and she responded well, ma'am. She is
okay. Thank you.
Okay, thank you, judges, and thank you, sir. Now I request Chauhan to present his case and Sneha Das to get ready for the next presentation.
Okay. So just let me present my screen.
Yes, sir.
Am I visible? Is my screen visible?
Yeah, yes, sir, your screen is visible. You can proceed, sir.
Okay, just a minute.
Okay.
Okay, right. Can I start now?
Yes, sir.
Good evening, judges, my fellow delegates, and all other dignitaries who are with us in this evening. I, Richa, would like to present a case of a giant phyllodes tumor which aroused a concern of cosmesis in the patient and a diagnostic dilemma to the surgeons. So, a lady who was 43 years old, female, came to our OPD of surgery in Arshika Medical College from a village in North 24 Parganas of West Bengal. She was a happy married homemaker. So we took a history of the patient. So the patient has a presenting complaints of a lump in the left breast, a cyclic pain in left breast. So she first noticed the lump in the left breast while taking a bath 6 years back. At the time, it was around 1 centimeter in diameter, according to her. Then over the years, it gradually increased in size to attain its current size, occupying almost the entirety of the extent of the left breast, associated with heaviness and dull aching pain in the same breast, which increases just before her menstrual periods every time. There were no other lumps present in the opposite breast, and both the armpits, according to the lady, were normal. She had no previous history of any disease or hospitalization or surgery which is relevant to this condition. Now, she does not take any medicine on a regular basis. She is unaware of any allergies. There is no history of breast or ovarian cancer in her family. She doesn't have any associated comorbidities as well. Now, the lady did not report of any psychiatric illness. The lady gets her menstruation regularly. She delivered a boy 15 years back by normal vaginal delivery who is doing well. There is no history of spontaneous abortions. The lady lives in a pakka house in a calm and quiet village with proper electric and fresh water supply. The lady does not consume alcohol or smoke. She denies consumption of drugs or any other addictive substances. So to summarize the history at a glance, there's a lump in the left breast of insidious onset with general gradual increase in size. There's a cyclic breast pain. There's no comorbidity or no family history of breast or ovarian cancer. Upon clinical examination, we found out a bosselated mass with variegated consistency. Over the mass, we could see prominent veins. The skin over the mass was shiny, and the nipple areolar complex, even though appeared grossly normal, was deviated laterally and inferiorly. Opposite breast was normal. Both the axilla and supraclavicular fossa were normal. Other systemic and regional examinations were normal. So after taking consent from the lady, and we took her to, we ensured privacy and examined her in presence of a female chaperone. So after that, we sent us for the radiology, and in radiology, we found out ultrasonography. In ultrasonography, there was a mass of 11 centimeter by 7 centimeter by 11 centimeter. The mass had both solid and cystic lesions and low-level internal echoes. The mass appeared to be multilobulated with minimal vascularity. Then the lady was sent in for a mammography. In mammography, we found a 11 centimeter mass in its greatest diameter and with rounded borders. Now, all these radiological findings indicated towards a BIRADS 3 breast tumor. Now, the lady was sent in for a preoperative core needle biopsy, and the biopsy findings showed hypercellular stroma, 3 mitosis per 10 high power fields, and no signs of pleomorphism. These were all consistent with a diagnosis of benign phyllodes tumor. Now, this is what our triple assessment looked at a glance. And then the lady was managed with surgery. The lady chose to underwent wide local excision, and the surgeons took out the tumor and sent it for histopathological examinations. The histopathology confirmed the preoperative biopsy findings. The lady recovered uneventfully without any local or distant recurrences. The patient follows up regularly at the OPD of Arjigar Medical College.
Sir, your time is running out. Can you please conclude it quickly?
I'm done.
Okay, thank you. Thank you, sir. I request judges to proceed with Q&A session.
Thank you so much for your presentation. It was amazing. Maybe Dr. Richa have any questions?
Yeah, thank you, Lolita. I have a few questions. First thing is 6 years. The lady noticed a lump 6 years back, and then she was waiting and waiting. Or did she visit any local doctor in between? Anyways, this question is for
Ma'am, even though she denied of visiting any doctors, but in West Bengal, there's a common practice in villages that people go to some alternative medicine people.
The mass was too big, you know.
We feared that we suspected that she visited, but she vehemently denied any visits. She said that she was not facing any problems, so she did not visit. The moment the pain was becoming a problem in her day-to-day life, she decided to come to a allopathic center.
Okay. And then another thing, you know, phyllodes tumor, these phyllodes tumor, they tend to become big, large in size. You did an ultrasound for your patient, and it's recommended now you do an ultrasound guided biopsy in these patients, because you do have areas of cystic necrosis. So if you get, you can get, or you can miss an underlying carcinoma. So you have to be careful. These patients, they may have an underlying component of soft tissue sarcoma, which you needs to pick up. And the treatment was wide local excision, but I'm not very sure if the surgeon was able to get a clear-cut margin and able to preserve some breast in tumor of this size.
Actually, ma'am, we were trying to offer the lady mastectomy, but
simple mastectomy should happen.
but since her family was not complete and she was very much worried about her cosmesis and marital life,
I think a breast reconstruction in these cases. But anyway, a phyllodes tumor, you need to do a wide local excision with clear-cut margin, negative margin.
And since, ma'am, our doctors saw that literature doesn't say that there's any added chances of survival with a mastectomy instead of a wide local excision, they thought of respecting her requests and went for a wide local excision.
You know, survival is not an issue with these patients. Recurrence is the main problem. So you need to get a clear-cut margin. Otherwise, go for adjuvant radiotherapy. If you're not very sure about the margin, go for adjuvant radiotherapy. Okay, thank you.
Okay, ma'am. Thanks a lot.
Thank you, judges, and thank you, sir. Now I request Sneha Das ma'am to present a case and Shreyanshi Bharadwaj to get ready for the next presentation.
Just give me a moment, please.
Okay, ma'am.
Is my screen visible?
Yes, ma'am. It's visible and you can proceed.
Just a moment. I'll just change it to the first slides. And is my screen shifting?
Yes, ma'am.
Okay, then I'll start. Thank you.
Thank you.
I'm Sneha Das, and today I'm presenting a case on leptospirosis with massive hemoptysis, which is an unusual initial presentation. So the patient history includes patient details where a 24-year-old married male daily wage laborer from South 24 Parganas, West Bengal, India, presented with fever and pained abdomen for 3 days, cough with hemoptysis and nasal bleeding for 1 day, and passage of high-colored urine and yellowish discoloration of eyes for 1 day. His history of present illness included a low to moderate degree fever for 3 days associated with nausea, malaise, and body ache, but no chills, rigor or sweating, and was relieved by medication. Dull aching and non-radiating pain in the right hypochondrium and epigastrium of the abdomen for 3 days with no vomiting. Massive hemoptysis around 150 to 200 ml for the last 1 day associated with nasal bleeding, and history of passing high-colored urine and yellowish discoloration of eyes since 1 day. So his past medical history included the history of a 4 to 5 day long fever 1.5 months back associated with chills, rigor, but no signs of jaundice that was relieved by medication alone. There was no history of tuberculosis or hemoptysis and no history suggestive of rheumatic fever or bleeding disorders. There was also no history of jaundice, blood transfusions, or intake of OTC medications. There were no abnormal surgical history. Personal history included no mention of smoking, addictions, or high-risk behavior, and no significant allergic or drug history. His bowel and bladder functions were normal. There was no significant history of jaundice among immediate family members. The possibilities we considered at this point were viral hemorrhagic fever, disseminated tuberculosis, viral hepatitis, and complicated malaria, which are the usual suspects for hemoptysis in this region. So the physical examination yielded an alert, conscious, and cooperative patient with hypopigmented patches on the skin and presence of pallor and icterus. The vital signs were all within the normal levels. The gastrointestinal examination showed a 1-finger palpable liver with mild tenderness with no intercostal tenderness and non-palpable spleen. Inspection, percussion, and auscultation did not yield any abnormal results. Other system examinations were also normal. In the investigations, the complete hemogram showed anemia, significant thrombocytopenia, as well as some levels of neutrophilic leukocytosis. Urine examination showed yellow-colored urine with presence of bile salts and pigments and significant levels of pus cells, about 4 to 6 per high-power field. Liver function tests showed rise in total and conjugated bilirubin up to the 7th day, but there was gradual reversal of the derangement by the 14th day. Alkaline phosphatase enzyme levels were also increased. Urea creatinine levels were increased up to the 4th day, but there was a reversal by the 7th day, and by the 14th day with conservative management, it had been reduced. The chest X-ray PAB on the day of admission showed extensive infiltrates involving both lung fields, which improved, and the lung fields were clear by 2 weeks. USG of the whole abdomen showed mild hepatomegaly with mild ascites and some rise in the cortical echo of the both kidneys. Prothrombin time was around 18 seconds, and other viral markers, especially for hepatitis, were all negative. Dengue NS1 antigen was negative, and sputum AFB CV-NAT were also negative. ICDC MP-MPDA were also non-reactive and negative, respectively.
Ma'am, you're running out of time. Please conclude it quickly.
Yes, Leptospira IgM was positive. So he was diagnosed with severe leptospirosis or Weil's disease, presented with massive hemoptysis, and was treated with injection penicillin, hemodialysis, and other supportive measures. He improved with conservative management and was discharged after follow-up with after 2 weeks of admission with no further complications. So to conclude, leptospirosis is a zoonotic disease, mostly mildly asymptomatic, but in severe cases, it is presented with fever, jaundice, and bleeding manifestations, as well as renal failure. However, in this case, the patient presented with massive hemoptysis as an initial presenting symptom itself, and clinicians should keep it in mind as a differential diagnosis of hemoptysis. Thank you.
Thank you, ma'am. I request our judges to proceed with Q&A session.
Thank you so much for your presentation. An interesting clinical case. Can you repeat, please, how you treat your patient?
Ma'am, we initially gave him penicillin, IV penicillin, about 1.5 million international units, 6 hourly for 7 days. And hemodialysis, it was more of a protective measure because kidney derangement has been only seen in the urea creatinine levels, but there was no hematuria as such. So hemodialysis was more protective. Other than that, we had some other supportive measures like we give ARDCA, ursodeoxycholic acid, for improvement of hepatic functions so we can control the jaundice. We give lactulose and pantoprazole to reduce hepatic stress and so that there was easier stool passage, and some hemostatic drugs mostly. He was well by the 14th day, so that was all. Thank you.
Okay. So he was discharged after 14 days, yes?
Yes, ma'am.
Thank you so much for the answer.
Thank you. No questions.
Thank you, ma'am.
Thank you, judges, and thank you, ma'am. Now I request Shreyanshi Bharadwaj, ma'am, to present a case, and Simar Salian to get ready for the next presentation.
Yes, I'm uploading it. Hello.
Yes, ma'am.
Can you see my screen?
Yes, ma'am, I can. You can proceed, ma'am.
Okay, okay. Good evening, respected judges. I am Shreyasi Bharadwaj and I'm a second-year medical student. Today I'm going to present the topic chondroblastic osteosarcoma of the tibia. This is my honor to present this topic even though this is of PG level. I decided to go through this topic out of interest, and I have tried my level best to go into the depth of this topic and understand it well. I hope you like my presentation. So for the introduction, the chondroblastic osteosarcoma is a histopathological entity which is characterized by predominant presence of chondroid matrix, which tends to exhibit high degree of hyaline cartilage and is associated with non-chondroid element. Moving on to the next slide, the patient, so this is a 31-year-old man who comes to the OPD with severe swelling in the left leg along with pain for the past 6 months. Also previously he had met with a road accident for which he was operated in the left proximal tibia. For the investigations, an MRI as well as a histopathological examination was done. So the MRI showed a large altered single entity lesion involving the proximal diaphysis and the metaphysis of the left tibia with erosion. And for the histopathological examinations, it was seen that an osteoid matrix was seen, which gave an confirmatory that it is an osteocarcinoma, and also it showed the presence of large oval-shaped tumors, spindle-shaped tumor cells, which was a suggestion that this is of the chondroblastic type. Also, a scintigraphy of the entire body was done, and this was to make sure if there was any metastasis of the carcinoma. So for the treatment, the person had to undergo chemotherapy followed by surgical resection of the tumor in order to avoid any possible limb loss. And the chondroblastic osteosarcoma is a malignant type of tumor, but and also it is most commonly seen in the knee region. This type of osteosarcoma is very less found in the tibia or maybe in the mandible regions, which have also been seen in some case reports. Thank you so much.
Thank you, ma'am. I request our judges to proceed with Q&A session.
Thank you so much for clinical presentation. So what about your patient? I want to ask, your patient has chemo, yes, after the operation and do not have before, yes?
Sorry, ma'am, could you repeat?
Yeah. Have your patient have chemotherapy?
Yes, ma'am. Yes, ma'am.
After operation, yes?
Yes, ma'am. First was the surgery and then post chemotherapy.
Okay, thank you so much.
Okay, Shreyasi, so your patient is a case of osteosarcoma, but for
Yes, ma'am.
for these malignant bone tumors, you need to stage the tumor. So you did a bone scan for staging. You didn't see osteosarcomas. They are lung metastasis is very common, and you need to rule out. So ideally, you can go for a CT thorax, or if a PET CT scan.
Ma'am, as you can see in the third slide, I had posted an MRI image.
An
Where
MRI of the bone you did, na? I'm talking about distant metastasis. Did you rule out lung metastasis? Because osteosarcoma is very prone to metastasize. That's why we start with chemotherapy, because chances of systemic metastasis is very common. So you need to, any sarcoma, you need to rule out lung metastasis. You should go for a CT thorax, or in ideal condition, if available, a PET CT scan. And then just start with a neoadjuvant chemotherapy. And then I would like to know now, what was the surgery, the type of surgery which was offered in your patient?
Ma'am, actually, he had come to our OPD in Ahmedabad, and after finding out about his case, he shifted to Bangalore, where he had undergone the procedure, the surgery.
Okay. So because your patient, what I could see now, the disease was very close to the knee joints. So I don't think limb sparing surgery would have been possible. So these patients, because osteosarcomas, they are radio resistant. So surgery is the only option for local treatment. So I suppose this patient must have gone for amputation followed by some prosthesis. And then of course we follow it with the adjuvant chemotherapy. Okay, thank you.
Okay, thank you, ma'am.
Thank you, judges, and thank you, ma'am. Now I request Simar Salian to present his case and Akash Shetty to get ready for the next presentation.
Is my screen visible and am I audible?
Yes, ma'am, your screen is visible and you are audible.
Okay. So, good evening, everyone. Today, I'm Simar Saluja, a second-year medical student from Lady Hardinge Medical College, and I'm here to present a case report of lymphoid blast transformation in CML, which was associated with myelofibrosis. So, myelofibrosis is one of the myeloproliferative disorders and is common in the elderly population. Therefore, the pediatric myelofibrosis is a rare entity and its prevalence is extremely low and has not been well elucidated in literature. There are two types of MF, primary and secondary. The primary myelofibrosis or the idiopathic myelofibrosis includes disorders. Hello, am I audible?
Yes, ma'am, you're audible.
Okay. The primary myelofibrosis includes disorders where no underlying cause for fibrosis is known. The secondary myelofibrosis in children is associated with certain hematologic malignancies, as can be seen here. The salient features of MF include peripheral blood cytopenias, leukoerythroblastosis, ineffective hematopoiesis, proliferation of dysfunctional megakaryocytes with reticulin and/or collagen fibrosis in the bone marrow, dysregulated cytokine production, and extramedullary hematopoiesis. So presenting the case now, a 7-year-old female child presented in the OPD with pain abdominal distension and fever for 3 months. The mother also complained of easy fatigability of the child. The abdominal pain was dull in nature, poorly localized, and accompanied with dragging sensation and heaviness in the left hypochondrium without any radiation to other parts of the abdomen. The fever was low grade but continuous. The birth history was uneventful, developmental history was unremarkable, and nutritional status was good. Past history was negative for previous such episodes, any chronic disease or any medications the child was currently on. Vitals were stable, GP was unremarkable except that the abdominal distension and slight pallor were documented. CNS, CVS and respiratory examination were unremarkable. Per abdomen examination revealed massive splenomegaly reaching up to the right iliac fossa and liver palpable 4 cm below the costal margin. Based on the history and examination, the differential diagnosis of certain infectious causes such as tuberculosis, typhoid, malaria, Kala-Azar, infectious mononucleosis (CMV), lymphohematogenous disorders such as lymphomas, leukemias, myeloproliferative neoplasms, and hemolytic anemias, and certain immunologic inflammatory conditions and storage diseases was made. So on investigations, the hemogram revealed marked leukocytosis with presence of 10% blasts having lymphoblast-like morphology, myeloid bulge, basophilia, and thrombocytopenia, which pointed out to the diagnosis of leukemia, probably CML. So we did an RT-PCR, which showed the BCR-ABL fusion protein, which confirmed the diagnosis of CML. So bone marrow aspiration was attempted, which resulted in a dry tap. Therefore, bone marrow to fine biopsy was done. So imprint smear shows the clusters of blast with lymphoblast morphology, as can be seen in this picture. On reticulin stain, grade 3 fibrosis was demonstrated, thus pointing out to myelofibrosis. On immunohistochemistry, clusters of blast cells were positive for CD34, 10, 19, 20, 79A, and PAX5. Therefore, it was B cell, and it was negative for T and myeloid markers. Flow cytometry similarly was performed in the peripheral blood smear, which was positive for B cell markers and was negative for T cell and myeloid markers. Therefore, final diagnosis of lymphoid blast transformation in chronic myeloid leukemia associated with myelofibrosis was made. The patient was given imatinib 300 mg per meter square once daily and was treated according to the ICI-CLE protocol. The child was responding well to the treatment.
Ma'am, you are running
on day
out of
5,
time. Please conclude it quickly.
Yeah, sure. On day 3, MRD was negative. Pediatric CML is very rare and is also very different from adult CML. The median WBC count in pediatric CML is significantly higher than adult CML, and splenomegaly is noted in 76% of the patients. Also, myelofibrosis is more common in adults than in children, and another study has shown that 11 to 20 years of age group have shown CML. However, it is rare in children. Of this child's age group, which was 7 years. So in conclusion, pediatric myelofibrosis is a distinct clinical entity with unique clinical and pathologic findings, which is primarily a diagnosis of exclusion. No definitive treatment apart from hematopoietic stem cell transplant has been proven to be therapeutic, and if currently diagnosed, may have favorable outcome after HSCT. Thus, early and correct diagnosis is the mainstay of treatment. These were my references. Thank you.
Thank you, Shima, and I request our judges to go with a Q&A session.
Thank you so much, Simar, for your presentation. And can you tell about us about follow-up of a patient after initial treatment?
Ma'am, actually, this was a very recent case which I saw. So, like I said, day 30, it was like around 1 or 2 months before only. So on day 35, we noted that MRD, that is the minimal residual disease, was normal. Like her spleen was not at all massive at that time, and we had done the PBS again for follow-up. So it did not show any blasts or lymphoblast cells there. And so we'll further be following up her. It was a very recent case I saw.
Okay, thank you so much. Maybe next year you'll continue to tell us about more. Thank you so much.
Yes, Simar, that is pediatric CML, really a very rare case. Can you tell me, did you go for any molecular studies in these patients? Because very rare, and ultimately these patients, some of these patients now, they do need a bone marrow transplant. So that is
yes, ma'am.
But then you need to classify the patient now initially. Now you need to go for, one is the hematological diagnosis, which you do with a routine blood test and bone marrow, a blood smear, and then you go for cytogenetic studies. And third is the molecular thing. If you do the molecular thing first now, then you can decide upfront that this patient needs to go for a bone marrow transplant, and then you give chemotherapy, accordingly.
Ma'am, actually, like in adults, we saw that myelofibrosis is associated with mutations like JAK2 and MPL mutations. So we had sent her for the genetic study, but the results are still pending. They haven't come yet. So we were also like thinking ki in adults, we know that the mutations are JAK2, MPL, and calreticulin, and then what about the children? Will the mutations be the same in them also? So we are thinking about that. So after the results come, we see it.
Okay, thank you.
And she was also responding well to imatinib. So, We see if
Then
she
you
needs
need
stem
to
cell
recheck the
transplant.
cytogenetic, the number of BCR, ABL transformation.
Yes, ma'am.
That is the main thing.
Yes, ma'am. So like after 6 months, we'll be rechecking for the cytogenetics. If the BCR ABL is normal, then like she's okay with it.
Okay, fine. Thank you.
Thank you, ma'am.
Thank you, judges, and thank you, ma'am. Now I request Shaka Shetty to present his case and Prakriti Ramurthy to get ready for the next presentation. Akash, sir, are you there?
Yeah, I'm here. Just give me a sec.
Okay.
Hi, can you see my screen?
Yes, sir,
as
it's
well as me?
visible. Yes, sir.
Okay, perfect.
You can proceed.
Okay. Just give me a second. Okay. So I will start in 3. Good evening, judges. I'm Akash Sethi, a final year medical student at Government Medical College, Baroda. The title of my presentation is Cholestatic Liver Injury Post-COVID, an Unusual Entity. Okay, could my timer be paused? It's showing that my net's unstable. Is there any issue from your side? Like, are you guys
Yes, sir.
able to
It's
see
good.
me?
You can proceed, sir. It's good.
Okay, sure. I'll continue. Okay. Case history. A 30-year-old male presented on 4th June to the OPD with yellowish discoloration of skin and sclera, nausea and anorexia since the past 25 days. On elaborating origin, duration, and progression, patient had itching 25 days ago on 10th May, then developed discoloration on the same day, which was progressive over the last month. Nausea was unrelated to food intake. There was no fever, abdominal pain, blood in vomit or stools, abdominal distension or swelling in legs. He had mild COVID 25 days before the onset of jaundice, that is on 16th April. Drug history, patient was on ivermectin for 5 days. Patient was on methylprednisolone on 5 days. Then the second steroid, that is deflazacort, was started. Patient was on favipiravir 1600 milligram for 10 days. Patient was also on anti-asthmatic medications. Patient was started on 15 days of aspirin and atorvastatin. And lastly, patient was on baclomethasone, rotacap for 15 days. On general examination, patient was conscious and cooperative. Vitals were within normal limit. Icterus was positive, and there was no other positive finding. On abdominal examination, a firm non-tender hepatomegaly with smooth border was felt. On percussion, liver dullness was found in the 4th intercostal space in the mid-clavicular line on the right side. Liver span was 14 centimeter. The other systemic examinations were non-significant. On investigations, the hemogram, albumin, globulin, RFT, coagulation profile, and upper GI endoscopy were within normal limits. The viral markers were negative. The autoimmune antibodies were negative as well. The direct bilirubin was 10.8, which was raised. Indirect was raised as well. SGOT, SGPT were within normal limits. ALP was 400, which is 2 times the upper limit, and GGT 250, which is the 5 times the upper limit. On CECT and USG, mild hepatomegaly was seen. On liver biopsy, marked cholestasis with bile plugs and bile thrombi are noted. This is the biopsy finding, in which we can see the bile plugs in the image. There were no gamma cells seen or no confluent necrosis or lobular inflammation, which ruled out autoimmune hepatitis. So basically, patient presented with itching, jaundice, and raised ALP. Therefore, the cause was cholestasis. Either it was intrahepatic or extrahepatic. In intrahepatic, it could be drug-induced, alcohol, viral, or autoimmune. And extrahepatic, it could be a malignancy, chronic pancreatitis, stone, or a benign stricture. All of these were elevated. If time permits, I'll be revisiting this slide. Diagnosis. The patient either has favipiravir or atorvastatin induced or direct SARS-CoV-2 induced cholestasis. There is evidence for both of these entities. For example, Jingjian had shown that patient has documented the presence of raised LFT after mild COVID, and Victoria et al. Has noted the presence of favipiravir induced liver injury. The R score was 0.5, which suggested cholestatic injury rather than hepatitis.
Sir, you're running out of time. Please conclude it quickly.
Yes, these are my positive finding: a history of drug intake, temporal association, and there has been evidence of previous evidence of favipiravir induced injury, and their other causes were excluded. Patient was on prednisolone for 50 total 20 days, and acetylcysteine also for 20 days, and ursodeoxycholic dose initially was 300 milligram BD, increased to TDS. This is the follow-up investigation. Patient is currently stable. His SGOT, SGPT are normal. Bilirubin have been reducing. Therefore, this is the take-home message. More research is needed to find the proportionality of these entities, and the routine patient on COVID the following drugs could be responsible. Thank you.
Thank you, sir. And now I request our judges to proceed with Q&A session.
Thank you so much, Rasha, for this presentation. I think on the era of COVID, we have a lot of more, if it's COVID or if it's medication. Yeah, we don't know, maybe. And so, because you suspect if it can be or medication or COVID, have you discontinued for the Piravir and atorvastatin in this patient?
No, we haven't distinguished, but it can be distinguished based on the two things. Firstly, atorvastatin usually leads to hepatic injury, that is hepatitis. Therefore, in this case, it's unlikely because the liver enzymes were normal. Therefore, hepatic injury is not suspected. Therefore, atorvastatin could be ruled out based on that. And ALP elevation with favipiravir is more likely. That has been recently documented. So it would be more towards favipiravir than atorvastatin.
Okay. Thank you so much.
Thank you, ma'am.
Okay, thank you, Akash. No questions from my side. Thank you.
Thank you, ma'am.
Thank you, Rajesh, and thank you, Akash, sir. Now I request Prakriti Ramurthy to present her case and Niranjan Raghavan to get ready for the next presentation.
Give me a minute.
Okay.
Is my screen visible?
Yes, ma'am, it is visible. You can proceed.
Okay, sorry, one sec. Yeah. So good evening, respected judges. I'm Prakriti Ramurthy, third year MBBS student from Ramaya Medical College, Bangalore. And under the guidance of Dr. Hamsa V, I'm presenting a case in pediatrics. So let's look at the case. So age, a 4-year-old boy hailing from Tumkur presented to the pediatric OPD with increased thirst noticed since early childhood, as well as increased frequency of urination. He was, the child had preference to liquids rather than solids, and he preferred drinking water compared to other liquids. The parents also noticed that the child had an increased frequency of urination since early childhood. The child passes urine 10 to 12 times a day and around 2 to 3 times at night in good volume, and the color was normal. There was no associated episodes of burning micturition or blood in urine. There was no history suggested of repeated episodes of fast breathing, failure to thrive, visual or hearing impairment. Past history, the child had a history of seizure at 3 months of life, and family history, the child was second born to a second-degree consanguineously married couple. The birth, immunization, diet, and developmental history was normal. The vitals were also normal. The anthropometry was also normal. On head-to-toe examination, frontal bossing was present and a broad forehead was noticed. The eyes, ears, nose, and oral cavity were normal. The face was non-dysmorphic. In the trunk, a Harrison sulcus was present. And in limbs, there was a widened wrist observed. There was no evidence of dehydration. Systemic examination was normal in all systems. Coming to the investigations, so in the serum levels, we noticed that the serum magnesium was low of 1.2 milligram per deciliter. The urine calcium to creatinine ratio was increased to 6.9, and the pH was also increased to 89.8 picogram per milliliter. The urine volume was biochemistry 24-hour urine calcium was 70.5, and 24-hour urine sit was 12. See the ultrasonogram on the screen where we can see bilateral 3 medullary nephrocalcinosis. So a diagnosis of Michaelis-Castrillo syndrome was made, which is a triad of familial hypomagnesemia, hypercalciuria with medullary nephrocalcinosis. And this diagnosis was made over renal tubular acidosis, diabetes insipidus, primary hyperoxaluria, and Bartter syndrome. The management was giving mainly supportive oral magnesium supplements. Therapy was given. Genetic counseling is recommended for the family prognosis, also the need for genetic evaluation. Sibling screening is also done. So coming to the case, this is Michaelis-Castrillo syndrome, LDN19 gene, which codes for the tight junction proteins, claudin 16 and 19, of the thick ascending limb of loop of Henry. And this reduced the paracellular reabsorption.
Prakriti ma'am, are you there?
Hello, can you hear me?
Yeah, I can hear you, but I can't see your screen.
Yeah, can you hear me?
Yeah.
Where did it get stopped? Oh, where did I get stopped?
I don't know. It's
I'm just going to continue from here. So, okay, I'm going to just continue from here. I hope you can hear me. So, less than 5 cases of this syndrome have been reported in India, and less than 200 cases have been reported in the world. The main age of presentation was 8 years. My slide changed? Okay, so it has a characteristic triad of hypomagnesemia, hypercalciuria, and nephrocalcinosis due to excessive renal magnesium.
Ma'am, you're running out of time. Can you please conclude it quickly?
End-stage renal failure by second or third day. Typically, is presented with recurrent polyuria, polydipsia. Yeah. Okay. So in this case, the patient presented with early polyuria and polydipsia, and the features related to the findings were consistent with the literature. These are my references, and thank you.
Thank you so much, Prakriti, for your presentation. It was interesting clinical case. And for me, it's like interesting that you need to treat this patient with thiazide diuretics, of course. And so you give your patients magnesium supply, thiazide diuretics, and how it was with this young patient if he started to feel better and his diuresis started to be lower.
I'm sorry, ma'am, can you repeat that?
Yeah, I'm asked what happened with your patients after initial treatment if the diuresis is lower now, diuresis.
Sorry, ma'am, could you repeat the question?
Oh, it's okay. Tell about follow-up of your patient.
Okay, so the follow-up will be, they have to check, they have to keep checking the electrolyte, monitor the electrolyte levels, and give magnesium supplementation so as to correct the hypomagnesemia. The treatment is mainly aimed at preventing the child from getting chronic renal disease and progressing to end-stage renal disease. And but according to whatever literature is available, the prognosis mostly leads to transplantation of kidneys in the next 2 decades. So,
thank you so much.
Thank you.
Okay, Prakriti. So, what's the prognosis of such cases?
Ma'am, so in all literature doesn't have a good prognosis, and all of the cases reported have usually ended up with the child having a chronic kidney disease, which is why the treatment is thiazide therapy to kind of reduce the progression of the nephrocalcinosis, and just to prevent.
Suggest renal transplantation in these patients?
Because what happens is that if you give a lot of supplementation, like on what's been observed is even with the supplementation and with the treatment, the kidney, the levels still the kidney still progresses to end-stage renal disease, and with even though the treatment can support correct the electrolyte levels, the disease progression cannot be stopped because it's actually a genetic disease, right? So,
any role of renal transplantation in these patients?
Sorry?
Any role of renal transplantation?
Yeah. So in where transplantation has been done, actually it's been noticed that the disease has not recurred after that. So in patients.
Okay, thank you.
Thank you.
Thank you, judges, and thank you, ma'am. Now I request Niranjan Raghavan to present his case and Sri Lakshmi MN to get ready for the next presentation.
Yeah, I'm presenting. And do let me know if my PPT goes off or if my voice breaks. Yeah.
Okay, okay, sir.
Sure. Thank you. Yeah, I'll just press some. Second. Yeah, cool. So a very good evening to everyone. So I'm Niranjan Raghavan, and I have a pretty interesting and a rare case, which I titled as crippling cancer. So let's get into it. So a 38-year-old man presented with a history of severe back pain and difficulty in walking for the past 6 months, which resulted in him being wheelchair bound for the past 3 months. So he had a history of generalized aches and pains for the past 2 years and history of pathological fractures of both necks of femur, and because of which he had to undergo bilateral hip replacement. Now, he had no history of aggravating or relieving factors or no significant family history. On examination, vitals were stable. General examination was normal. But on CNS motor examination, he was found to have proximal myopathy. So I have a video of the crippling walk of the patient. And so, yeah, this was the mobility of the patient. And on biochemical examination and investigation, low alkaline phosphatase levels were seen. There was severe hypophosphatemia and high parathormone levels. And biochemical analysis of urine also revealed phosphaturia. So negative biochemical parameters were done so that to rule out differential diagnosis. So we can see that his vitamin D3 and calcium levels were normal, and there were no autoimmune diseases. So electroplasmapheresis was done to rule out multiple myeloma, and there was no MBAN found. So now the endocrinologists, they now suspected a tumor which was secreting hormone. So they did a functional Dotanoc PET CT scan using gallium-68, and you can clearly see the uptake of gallium-68 in the nasal region. So this is the axial section, and you can see a left nasal mass. This is the coronal section. And on radiology, on MRI of the nose and the paranasal sinuses, there was again a mass in the superior aspect of the left nasal cavity. There was no intracranial involvements, and there was no involvement of the dura either. So on diagnostic nasal endoscopy, it revealed a smooth globular non-pulsatile mass in the left nasal cavity between the nasal septum and the middle terminates, which does not bleed on touching. And on X-ray, which is this is a very characteristic sign of osteomalacia, which is called milkman lines or Lucas zones. So for surgical management, an endoscopic complete excision of the left sinonasal mass was done using a cobblator, and intraoperatively, there was no bone erosions or CSF leak seen. Medical management included pre-op high-dose phosphorus, which improved the patient's symptoms. Post-op oral phosphorus and vitamin D was given, and a follow-up every 3 months with annual screening has been recommended. So on HPV examination, the microscopy showed sections of an ill-defined lesion lined by pseudostratified columnar epithelium composed of oval to spindle out tumor cells. So on IHC, it was for the positivity was shown for CD56, Vimentin, and SAT-B2. So based on these features, a diagnosis of a phosphaturic mesenchymal tumor was given. So here's the final diagnosis. So this is a case of a sinonasal phosphaturic mesenchymal tumor leading to oncogenic osteomalacia. So PMT is a very rare neoplasm of the bone and soft tissue, which is a common cause of TIO, or paraneoplastic syndrome, caused by tumor cell secretion of hormones that impair renal phosphate reuptake. So FGF23 is the most common of these hormones. They are known as phosphatonins. PMTs most commonly are seen in the extremities, but around 5% of cases account for the head and neck sites. And PMTs are usually clinically benign in fashion, but around 10% will recur according to a study. And in conclusion, so this case highlights a rare disease presenting in an extremely rare anatomical location. So a timely and an accurate diagnosis is thus imperative for initiating proper treatment in patients with suspected TIO. So this diagnosis should be entertained in any patient presenting with osteomalacia and a newly identified mass. This case also reinforces the importance of incorporating phosphate assays in the first-line evaluation of unexplained unusual musculoskeletal disorders. And since recurrence and metastasis have been reported, long-term clinical follow-up is recommended. Here are my references, and thank you.
Thank you, sir. Now I request our judges to proceed with Q&A session.
Thank you so much, Jen, for your clinical piece. I have no question.
Thank you, ma'am.
Okay, Niranjan, that was really a very rare case. And of course, with the use of, with the recent advent of PET-CT and so many different types of radionuclides, we do, end up diagnosing with these rare cases.
Yes, ma'am.
I would just like to see the follow-up of this patient.
Actually, in fact,
how did this patient respond to treatment? Do you have a video?
I don't have a video, ma'am. Actually, this is a very recent case. So it's hardly been 3 months since the recurrence. And actually, we ringed him up today. So we wanted to follow up with him. And actually, he measured his phosphate levels. So the phosphate levels came back to normal. And his crippling walk is not there anymore. He's able to stably walk without any support. And all the other symptoms are also diagnosed slowly.
So, this case would suggest a routine use of PET-CT scan. If you can't find anything and there is a symptom, go for PET-CT scan.
Yes, ma'am. Sure.
Nice case. Thank you.
Thank you, ma'am.
Thank you, judges, and thank you, sir. Now I request Sri Lakshmi ML to present a case and Chauhan Ghosh to get ready for the next presentation. I'll share your screen. One second. Ma'am, I can't share your screen. I'll just see it. In the meanwhile, can I request Chauhan Ghosh to present his case and Toshi Sengupta to get ready for the next presentation? Chauhan sir, are you there?
Yes, ma'am, I am there. Just give me some time.
Okay.
Okay, let me know if my screen is visible.
Yes, sir, your screen is visible.
Okay. So, just a minute. Hello, everyone. I am Chauhan Ghosh, a student of 6th semester from Medipur Medical College and Hospital. First of all, good evening to all the judges and audience. Dr. Indrojit Sen was my guide in this case. My case is a real or atypical presentation of dermal rhinosporidiosis. So these are the highlights. A 48-year-old male from Kotwali, Mednipur visited our OPD with recurrent nasal and ear bleeding and some spots on the skin. He gave the history of recurrent bleeding from nose, a mass in the nose for last 1.5 months, and the lesion and spot on the skin for last 30 days. He gave a history of foul smells from surroundings for last 5 days and headaches for last 5 days. The patient present with a history of bloody discharge from his nose and ear for a month or so. Patient saw a mass in the nose from last 1 month. Some black eruption was noted by him on the forearm and the leg region. Otherwise, patient was asymptomatic, but for last few days, patient complains of foul smell from the surroundings and felt excruciating headache in the forehead area, so he decided to come to the nearby hospital for checkup. The history are as follows. There was no history of allergy, no history of anosmia. The highlighted personal history is there is no history of pond bathing or using the pond water, no history of cattle breeding, but he often works in the paddy field. There is no family history of allergy, hypertension, diabetes, TB, syphilis, malignancy, etc. So on examination, the patient was alert, conscious, and coordinative, well-built, and the vital signs were normal. On local examination of nose and PNS, swelling was found on left nose. The swelling was sessile, pinkish granular, mobile, of 1 centimeter diameter that bleeds to touch. The anterior rhinoscopy shows swelling mass in the lateral wall of the nose, and the posterior rhinoscopy shows large bulky mass in the nasopharynx, and there are maggots. The examination of PNS was apparently normal. The ear investigation shows a mass in the helix area, which bleeds to touch. The local examination of the skin shows soft blackish granulomatous lesion of 0.5 centimeter diameter, or more or less round or ovoid in shape, non-tender, is seen on forearm and skin on the posterior aspect of the knee. Routine blood tests for hemoglobin, TLC, DLC, BTCT, HIV, hepatitis were given. Culture and sensitivity of nasal discharge were given. X-ray chest, liver function test, nasal endoscopy, and ECG was given. And the findings were within the normal limits. As you can see, the X-ray is normal. Then we ordered a biopsy.
So your time is running, so please conclude it quickly.
Okay. So the biopsy report confirmed the diagnosis to be of rhinosporidiosis. Here are the differential diagnoses, that is aspergillosis, blastomycosis, rhinosperoma, nasal polyp, and all others. The treatment. First of all, the maggots were removed and the patient was isolated for some time. And after that, complete excision of the mass was done and cauterization of the base was done with diathermy knife. A prognosis follow-up as written here. Now discussion. Generally, why this case is rare? Because rhinosporidiosis is common in nose, nasopharynx, oropharynx, and other area, but the involvement of skin is very rare. In generally, bathing in ponds and muddy waters was considered a risk factor by several authors, particularly pond bathing with animals. But in this case, the history of pond bathing was not there and no history of cattle breeding was there. As you can see, the disease is caused by Rhinosporidium severi. Here is the life cycle. Here are my references. So thank you, SMR, for this opportunity.
Thank you, sir, for your case. I request our judges to proceed with Q&A session.
Thank you so much for the clinical case. I have a question.
So, I mean, I just want to ask a question. How do you diagnose rhinosporiodosis? And what is the role of doing IHC?
Sorry, ma'am?
How do you diagnose rhinosporiodosis? And what is the role of an IHC?
Ma'am, rhinosporiodosis can only be diagnosed by the histopathology test. Okay,
Yeah.
the histopathology.
Would we go for an IHC in this case if it was a clear-cut diagnosis on histopathology?
No, ma'am. Because as there are skin lesions, we were not sure that the skin lesions were due to rhinosporiodosis or anything else. So we take biopsy from the skin lesions and the ear. So it confirmed that the skin lesions were also from rhinosporidium.
Okay, so what are the markers you use in IHC for confirming rhinosporidium?
The marker was there were globules, okay, and CD4, CD4 and CDT T cells were there, and macrophages were there.
Okay, thank you.
Okay, ma'am.
Thank you, judges, and thank you, ma'am. Thank you, sir. Sorry. Now I request Toshishan Gupta to proceed with the case and Abhishek Patti to get ready for the next presentation. Ma'am, are you there?
Can you see my screen?
Yes, ma'am, you can proceed. It's visible.
Okay. So today I'll be presenting a case on multicentric Castleman disease with POEMS syndrome. So this was a case presented to us by our residents this last December. So it is a case about a 33-year-old female single Roman Catholic with chief complaint of abdominal enlargement. So the interval history was quite long. The patient first presented in 2017 with a right submandibular mass. Next consultation was made on July 2019 with complaints of dizziness, body malaise, and hypertension. On September 2019, she presented to the clinic with blurring of vision, enlarging mass, and weakness of lower legs. Next consultation was done in October 2019 with complaints of weight loss, bipedal edema, decreasing menstruation, and skin lesions. And finally, on July 2020, she was admitted to hospital with bipedal edema, abdominal enlargement, and difficulty of breathing. So a past medical history was significant for hypertension and thyroglossal duct cyst. Family history had hypertension and diabetes on the maternal side. Personal and social history was unremarkable. So endocrine showed menstrual irregularities. Neuropsychiatry showed weakness of hands and feet, numbness of hands and feet, musculoskeletal joint pains, bone deformity, restriction of range of motion, and general survey showed the patient was awake, conscious, coherent, not in cardiorespiratory distress, and the vital signs were normal. So the skin showed maculopapular rashes all over the body, which spared head, palms, and sole. Head and neck showed bilateral non-tender cervical lymphadenopathy. Direct tenderness was present, and there was shifting dullness as the patient presented with abdominal enlargement, which was ascites. Neurology showed glove and stocking distribution of loss of sensation. There was wrist drop present, claw, hand, and foot drop, which signified loss of ankle dorsiflexion. Musculoskeletal system presented with joint pain, bone deformity, and restricted range of motion. So the problem list was, it involved like almost every possible system: cardio, gastro, rehab, neuro, endo, nephro, even optha, and ENT, of course, showed bilateral cervical lymphadenopathy. So we did a chest CT contrast, whole abdominal CT, cervical lymph node excision biopsy, and immunohistochemistry, CBC, and blood chemistry. And also a lot more investigations were done, which was not possible to include here, since it was like a 40 pages of investigation, 3-year-long case. So the summary was HEMA, neuro, rehab, and optha were referred, and HEMA noted the biopsy findings of Castleman disease from the cervical lymph node biopsy and noted the possible multicentricity of the nodal involvement upon review of available chest and abdominal CT scan. Neuro noted the chronicity of the neurologic symptom and its gradual progression. Rehab noted the peripheral neuropathy, and Ophtha was suspecting optic neuritis, and there was a referral made to neuro-ophtha specialist, and a cranial MRI was requested, but the patient did not continue with it due to financial constraint. So the lymph node biopsy showed the diagnosis of Castleman disease, which was of hyaline vascular type, and immunohistochemistry stains for cytokeratin, CD45, CD34, OCT2, and HHV8 for a more definitive diagnosis.
Ma'am, you're running out of time. Can you please conclude it quickly?
Yes. So for the Castleman disease lymph node, we have two types. So our is categorized under the clinically multicentric POEMS associated MCD, and it had the hyaline vascular subtype. So this was the lymph node of a biopsy noted in our patient, which was the hyaline vascular type. And this is the criteria for diagnosis of POEMS. The mandatory major criteria, polyneuropathy was present. Other major criteria, one required, Castleman disease was present, and minor criteria, organomegaly, extravascular volume overload in form of ascites, endocrinopathy, and skin changes as in forms of maculopapular rash, all were noted. So the differential diagnosis we came were SLE, multiple myeloma, and EBV associated lymphoproliferative disorder. So for POEMS syndrome, P for polyneuropathy, O for organomegaly, E for endocrinopathy, M for monoclonal component, and S for skin changes. So the limited disease is radiation therapy, and for advanced disease, we go for chemotherapy, bortezomib, and lenalidomide. So these are the treatment outcome in patients with POEMS syndrome. This is from a journal. And this is how we manage the Castleman disease. So since it was the severe variety, we usually give siltoximab plus steroids. And prognosis is chronic debilitating course, median survival of 13.7 years. And extravascular
It's over 5 minutes, ma'am. Can you please conclude it quickly?
So the extravascular volume overload is of 6 to 6.6 years since ascites, and patients are followed annually with CT and laboratory studies. Annual imaging may be discontinued after 5 years if the patient remains disease-free, but here the patient lost follow-up due to the pandemic in between, and then in July 2020, when she was admitted, we ultimately lost her in August 2020. So these were the journal references for my presentation. Thank you.
Thank you, ma'am. I request our judges to proceed with the questions.
Thank you so much for the amazing presentation. Please, can you answer how many doses of rituximab or something what patients had for tocilizumab?
Doc, actually, the patient did not continue with the chemotherapy, which was, she came in July 2019, and then again she was admitted in October 2019 with the chief complaint of abdominal enlargement. So the ascites was controlled with furosemide, and even the dialysis was, because her kidneys were also showing some abnormalities. We tried to take abdominal CT, but due to azotemia, the CT was getting, deferred, because in presence of azotemia, a whole abdominal CT was not possible. So then, due to financial constraints, as soon as the edema got controlled, the patient, signed and left. So then the pandemic started, and then when the patient came back in August 2020, then I think each and every organ was involved, and the patient succumbed very quickly. So even before our doctors could proceed or do anything, or start with chemotherapy, the patient was having financial constraints also, and since it reached a very severe stage, so we lost the patient within 3 weeks.
Thank you so much for your answer.
Thank you, ma'am.
Okay, so did you treat your patient only with the monoclonal antibodies? Because rituximab is quite, it's a costly drug. So the patient had financial constraints. So any other options you have? Such patients?
Actually, doc, when the patient first consulted, since you saw it was a 3-year-long history. So in 2017, when she first consulted, we were not considering this rare type, because we are always taught that you have to consider diagnoses which are more common. So, we were thinking of multiple myeloma, maybe EB associated, all the differentials which I mentioned. So we were trying, we were doing MRA scan, which turned out unremarkable. We did a MRI of the lumbar spine, which showed numerous osteosclerotic lesion. Then, ma'am, lots of tests were done. The biopsy was done. So ultimately, when the cervical lymphadenopathy biopsy was done, then we were able to come to a conclusion that it was Castleman disease of hyaline vascular type. So when our hematology specialist and the hematology oncologist, our senior oncologist, she told her that, there are certain therapies available. And since her stage is already, it's in the severe stage. So there is actually, ma'am, no available literature for particular therapy. It's all based on the journals. So she was told that she will be needing chemotherapy, but then she said that she will come back later. And for the time being, since her problem was difficulty of breathing due to the ascites, she wanted that to be controlled. So a nephrologist was consulted. She was given furosemide and all the other symptoms. We were trying to control it rather than the root cause, because she was not consenting to start the chemotherapy due to the financial constraint. But then, ma'am, due to the pandemic, everything was shut down. She could not come. And then when finally in August 2020, she came, that time it was just too late. And, even with a multidisciplinary approach, we were not able to save her.
This is just one question. If the patient had a gross lymphadenopathy, there were nodes in the cervical region, abdomen, everywhere. So if there's a dictum in oncology, if you can see something gross, go for a biopsy, at least an FNAC. I mean, doing a biopsy of cervical node, that is a routine procedure.
Ma'am, the thing was
in 2000 diagnosis.
In 2017, ma'am, when she presented, she did not have any cervical lymphadenopathies at all. In 2019, October, when she presented, there was cervical lymphadenopathy unilaterally. So then our doctor referred her for a biopsy, which again, she deferred due to financial constraint. And that was when she lost to follow up. And then next, ma'am, when she consulted, it was already August 2020. So after October 2019, she came directly at August 2020 with ascites, edema, and like all these symptoms were present. So the stuck and gloving neuropathy. So all the systems were involved. And that time it was just too late to even with aggressive therapy for 3 weeks, it was in vain.
Okay, thank you.
Thank you, ma'am.
Thank you, ma'am, and thank you, judges. Now, I request Abhishek Pati to present his case and Sri Lakshmi MN to get ready for the next presentation.
Am I audible?
Yes, sir, you're audible.
Okay. Good evening, everyone. My name is Abhishek Pati. I'll be talking about a case of on leprospiral meningitis. So the patient particulars are: patient was 25 years old, male, single, Roman Catholic. The chief complaint that the patient presented with was decrease in sensorium. The interval history is 10 days prior to consultation. Patient experienced dizziness and nausea upon waking up in the morning. Patient self-medicated with Sturgeon, providing temporary relief. 8 days prior to consultation, recurrence of symptoms now accompanied by low-grade fever, undocumented, diagnosed by a local clinician with acute viral illness, prescribed with paracetamol. And 5 days prior to consultation, fever was still recurrent, now accompanied with maculopapular rashes distributed more on the dorsal part of the body. 2 days prior to consultation, his fever was noted to be worsening, now with a temperature of 38.5 degrees Celsius. Maculopapular rashes were still persistent. Now he reports of experiencing severe muscle pain all over and headache as well. Few hours prior to consultation, he was noted to be weak looking and drowsy, and hence brought for consult. So the past medical history patient had previously allergic rhinitis, and appendectomy was done 12 years of age. And in family history, his father is 65 years of age and he has hypertension. His uncle was deceased at 50 years of age with non-Hodgkin's lymphoma. For review of system, the patient presented, as I mentioned, with maculopapular rashes generalized with confluence on the dorsal region, especially on the posterior thorax midline. And as for hint in eyes, patient had conjunctival suffusion, and patient also had dental caries, mostly on the molar areas, and positive gingivitis. In the neuro exam, patient showed positive Doll's eye reflex, and as for the meningeal signs, patient showed positive for nuchal rigidity, Brudzinski sign, and Kernick sign. The glaucoma scale was 7 with E2, V2, and M3. Patient was drowsy, unsustained wakefulness. For physical examination, patient is stretcher borne, not in distress. Patient was noted to be drowsy with unsustained wakefulness. The blood pressure was 80/69, and the pulse rate was 120 beats per minute. The respiratory rate was 22 per minute, and the temperature was noted to be 40 degrees centigrade. And as for diagnostic workup, microscopic agglutination test, which is the gold standard in leptospirosis, which we suspected, was done, and LAT was also done, and ELISA IgM was done. And as for the direct detection method, PCR and a dark field microscopy, and as for culture, culture is usually in the first 5 or 7 to 10 days. We use blood, and after 7 to 10 days use fresh urine, and its positivity is 3 weeks to 3 months. The differential diagnosis were meningococcal meningitis, chikungunya, and dengue fever, which were all ruled out. So
you're running out of time. Can you conclude it quickly?
So our patient was in the anecteric phase, as patient showed fever, conjunctival suffusion, and meningitis, and meningitis and rash also. So the medication which was given in our patient was doxycycline 100 mg per os, and these are the other regimens which is usually given in mild and moderate to severe leptospirosis. And as for the prognosis, outcome is generally favorable in patients with leptospiral meningitis treated with antibiotics. And for the follow-up, usually outpatient follow-up may include an assessment of renal function to ensure outgoing reversal of any damage. A cardiac assessment may be indicated in patient with symptoms suggestive of heart involvement. But in our case, the patient, maybe he did not show up for a follow-up because after the treatment with doxycycline, patient maybe he decided not to show up. So yeah. Thank you.
Thank you, sir. I request judges to proceed with Q&A session.
Thank you so much for the presentation. Can you repeat, please, about follow-up?
Yes, doc. Yes, doc. So, doc, as I said, for the follow-up, patient did not follow up. We told him to follow up, but he decided not to follow up, maybe due to financial problems, I guess, or I don't know why, but patient decided not to follow up. Maybe after the treatment of doxycycline for 7 days, patient decided not to follow up after he was discharged. Hello?
Hello. Hello.
Hello?
Yeah, Abhishek, just regarding follow-up, now most of the patients, you see, it's a common problem. The patient don't follow up, but when you're presenting a case
Yes, ma'am.
and something, now you can just call the patient, go for a telephone. You can just ask that what is the status of the patient. That will somehow, complete your case report. Is the patient asymptomatic, or the patient has died of the disease, or the patient is having more complications? So even if the patient doesn't come back for follow-up, when you're presenting a case report or something, you can just call the patient and get a telephonic follow-up. So that will, sort of complete your case report.
Ma'am, this case was actually discussed with us by our senior residents while I was in my IM rotations, and I'm currently studying in the Philippines. So most of the patients are Filipino patients, so it's kind of hard to converse with them. So this was discussed to
That's
us. Yeah.
just a general suggestion now.
Yes, ma'am. Yes, ma'am.
Okay, thank you.
Thank you, judges, and thank you, sir. Firstly, I'm very sorry, judges. It's taking more than 10. I'm really sorry. We are left with 4 cases. I hope you'll cooperate, ma'am. Thank you so much. Now I request Sri Lakshmi Amen to present a case, and Monisha Datta to get ready for the next presentation. We'll be sharing your screen. Just a second.
Yes, I will share screen. 1 minute. Can you see the Can you see the
Good evening,
screen?
all.
Yes.
Hope I'm audible and visible.
Yes, ma'am, you can proceed.
Yes. Yeah, I'm Sri Lakshmi Amen, third prof MBBS student from Bangalore Medical College and Research Institute. And this is the unique case I'm going to present. Of course, unique, please go back. Please go back to my first slide. Yes. So this is the unique case that I encountered in my OPD. This is a case of ciliary obesity, which left me with that such a minute structure can even cause catastrophe in the life of an individual. This is the original case done by me. Here comes the protagonist of my case, who is a young 14-year-old boy who came with a complaint of bilateral nasal obstruction since a long period of 9 years. He was apparently normal 5 years back, developed a nasal obstruction, insidious in onset, gradually progressive, aggravated during winter, relieved by medications. Next slide, please. Yes, he also had a complaint of nasal discharge and facial puffiness since 5 years. No significant past history and no similar complaints in the family. Proceeding with general examination, it was not remarkable, no significant findings. Local examination. Yes, on anterior rhinoscopy, we found that he had a minimally deviated nasal septum at right side, which could probably answer nasal obstruction. And otoscopic examination, there was retraction of tympanic membrane and bilateral minimal hearing loss. No, 1 slide back, 7th slide, yes. No other significant findings except that there was coarse, creaky, leathery crepitation heard on auscultation, which made us think that there could be mucus consolidation in his lungs. And we proceeded with chest x-ray, which literally left us wonderstruck that he was a case of dextrocardia. His apex of heart was seen on the right side, which led us to suspicion that whether it is only confined to heart or any other visceral organs, which prompted us to perform abdominal USG, and which confirmed the suspicion that there was a liver and IVC on left side, which was supposed to be on right, and spleen on right side, which was a suggestive of situs inversus. Then we proceeded with next slide. X-ray of PNS because he had a complaint of facial puffiness. So this confirmed pus sinusitis and deviated nasal septum on right side. So finally, we could arrive at the diagnosis of cartilaginous syndrome because he had a typical triad of situs inversus, chronic sinusitis, and bronchiectasis. So this was a straightforward diagnosis of cartilaginous syndrome. The treatment modalities that we had for this patient was functional endoscopic sinus surgery. Because he was in a pediatric age group, we couldn't go for FESS due to anesthetic considerations. So we went with antibiotic treatment for pulmonary infection, bronchiectasis, and otitis media. Next slide. Next slide. We ruled out all the possible differential diagnosis of allergic rhinitis. Please, next slide. Allergic rhinitis, malignancies, etc. Hello. Can you please proceed towards the next slide? Pardon? Yeah, we ruled out all the differential diagnosis, possible differential diagnosis of cystic fibrosis, allergic rhinitis, etc. Then, okay. Yeah, please, previous slide. Yeah. Prognosis, patient is currently doing well with antibiotics and nasal decongestants. Now throwing some light on what is this.
Ma'am, you're
cardiogenic
running
syndrome
out of
about.
time. Please conclude it quickly.
Autosomal recessive disorder, which is a triad of cytosine sinusitis, and bronchiectasis. Pathogenesis, it is a rare autosomal recessive disorder, and 90% of affected individuals will have structural defects in a diamine protein. Genes affected as DNA-I1 and DNA-H5. Next slide. It is basically, there is dysmotility of cilia, which get manifested as recurrent infections of lungs, otitis media, infertility. Please, next slide. Yeah, previous slide. 16th slide.
Internet problem, I think you can continue.
Yeah.
So
there is defective movement of cilia, which get manifested as recurrent chest infections, ear, nose, throat problems, and infertility. Yeah, thank you.
Thank you, ma'am. I request our judges to proceed with Q&A session.
Thank you so much for your clinical presentation. Please say how you treat your patient. Do you say like you need to like treat infection, and how actually you treat this patient?
Yes, because this patient had sinusitis, facial puffiness, which aggravated during winter, we gave him antibiotics, macrolides, azithromycin, amoxicillin. We also gave inhalational corticosteroids. We also emphasized on physiotherapy to improve his lung capacity. As of now, he's doing really good. Yeah. So we need not go for submucosal resection septoplasty to correct his deviated nasal septum, because he's in pediatric age group. So considering his bone development and all, we couldn't go for it. So as of now, he's doing good with this.
And how long he took corticosteroid?
Initially, when he had aggravations, he took inhalational corticosteroids. Then we monitored his PF, his pulmonary function test. He was really doing good. So we stopped that at the time.
Thank you so much.
Thank you.
No questions from my side. Thank you.
Oh, thank you.
Thank you, ma'am, and thank you, judges. Now I request Monisha Datta to present her case, and Prerna to get ready for the next presentation. Sorry, ma'am.
It's okay. Is my slide visible?
Yeah,
Am
it's
I
visible.
audible?
Yeah, you can proceed.
Yeah, thank you. Good evening, honorable judges and everyone present over here. I am Monisha Datta, and my case is on platypnea orthodoxia with impending paradoxical embolism. Platypnea orthodoxia syndrome is characterized by onset or worsening of dyspnea with orthostatism and arterial desaturation that is relieved by returning to recombinant position. Paradoxical embolism refers to an embolus that originates within the venous circulation and enters the arterial system. The case unfolds: a 62-year-old female patient presented with chief complaints of dyspnea for 3 weeks, confusion, slurred speech, and right upper and lower limb weakness for 2 days. Her dyspnea was progressive in nature, which increased on exertion. 3 days ago, it progressed to her being unable to walk for more than a few steps, with no history of headache, fever, orthopnea, PNT, or swelling of legs. She also acknowledged a sudden onset confusion, slurred speech, right upper and lower extremity weakness with low loss of consciousness, neck stiffness, or palpitations. Her past medical history was significant for a B-cell leukemia 2 years ago, followed by a deep vein thrombosis of left lower limb 15 months ago. She had no history of hypertension, diabetes, illicit substance use, and denied any significant family history. On general examination, the patient was found to be alert, conscious, and cooperative with no pallor, icterus, cyanosis, or lymphadenopathy. Her vitals were rotated for slight tachypnea and an oxygen saturation of 85% while breathing ambient air. Neurological examination reveals mild right upper limb motor weakness with pronated drift, right facial droop sparing forehead, and NIH stroke scale was calculated to be 3. Cardiovascular examination revealed normal heart sound and a grade 2/6 holosystolic murmur at left lower sternal border, which increases with inspiration. Respiratory examination showed the lungs were clear to auscultation. Baseline investigation were all within the normal range, and arterial blood gas analysis showed an increased alveolar arterial gradient. MRI of the brain revealed multiple small foci of infarcts with lesions of hemorrhagic transformation in various locations, which are consistent with microemboli. Chest X-ray showed moderate scoliosis and clear lung fields, and CT of chest showed small segmental and subsegmental pulmonary emboli on the right side. Transesophageal echocardiogram revealed normal biventricular function and a mass of 1.2 by 2.3 centimeters size attached to the septal leaflet of the tricuspid valve. It also showed a moderate tricuspid regurgitation. Thus, the mass could be of neoplastic or non-neoplastic origin. Neoplastic differentials being metastatic lesions, myxomas, papillary fibroblastomas, and non-neoplastic differentials being thrombus and cardiac vegetations. She was given a supplemental oxygen, but despite that, she remained persistently hypoxemic, which is a hallmark of shunt pathology. In her case, her right to left shunting was made worse with upright positioning, a phenomenon known as platypnea orthodeoxia syndrome. Bedside echo with agitated saline was done, which revealed an early microbubble appearance on the left side of the heart, consistent with intracardiac shunt. It also showed an eccentric tricuspid regurgitant jet directed along the atrial septum and across the patent foramen ovale. Thus, a diagnosis of platypnea orthodeoxia syndrome with impending paradoxical embolism was made. She underwent operative resection of mass and closure of patent foramen ovale. The microscopy of the mass revealed thrombus. Her post-operative course was uncomplicated, and on 1-month follow-up, she remained symptom-free with a peripheral oxygen saturation of 96% in upright posture. So to conclude, this case is an example of diverse clinical manifestation of a patent foramen ovale, which is usually asymptomatic. PFO can lead to right to left shunting in cases of increased right chamber pressure or when blood is directed across it. Also, right-sided thromboembolic disease in presence of PFO can produce paradoxical systemic embolization. Thank you.
Thank you, ma'am. I request our judges to proceed with Q&A session.
Thank you so much, Manisha, for your clinical presentation. Please say, after the operation of your patient, what was the treatment after the discharge? If your patient had anticoagulation?
Ma'am, the patient was symptom-free after the discharge, so we only gave her infraction heparin for the thrombosis and nothing else was bigger. And she was on rehabilitation for the neurologic manifestations she had.
Yeah, I mean, like after when you delete thromb, yes, and like in this case, and treat like with heparin, you can have some risk that it can return, maybe like some like 3 months or something, or like this patient was fine.
Ma'am, can you please repeat?
Oh, I mean, like ordinary, sometimes when you delete thromb after subatrial, you continue anticoagulation like from 1 to 3 months. What about if this patient hadn't, if she was okay after the 3 months, she hadn't like any thrombus again?
No, ma'am, she didn't have any thrombotic episodes after that. And we asked her to come back if she had any residual dyspnea after the patient, but she was fine.
And the answer is the oval septum was closed, oval defect. Yes, and how old was patient?
How?
How old?
Ma'am, 60-year-old.
60-year-old.
Yes.
And it totally closed. Yes, she hadn't any pulmonary hypertension.
No, ma'am, she didn't have any pulmonary hypertension.
Okay, thank you so much for the answer.
Thank you. Thank you.
Monisha, I remember you mentioned this patient had a history of B-cell leukemia. So was she on active treatment for leukemia?
Ma'am, she was currently on maintenance therapy of B-cell leukemia.
Which drug?
Ma'am, methotrexate, vincristine, and 6-mercaptopurine.
Okay. And then you could operate because leukemia, usually the treatment is very long. And, what was the status of platelet count and all that, total count?
Ma'am, the platelet count was currently normal, in normal range.
You are treating with antithrombotic agent also, no? So you have to be
Yes, ma'am.
careful, no? It's a leukemia patient. Okay, thank you.
Thank you, ma'am.
Thank you, judges, and thank you, ma'am.
Yeah, this is a part of promotion of our educational partners. Just we have 10 more slides. I will go through and then we can end up with the final presentation. The next participant can proceed.
Yeah. Now I request Prerna to present her case. This is the last case.
Okay, I hope that I'm visible as well as audible.
Yes, ma'am.
Is my screen visible as well?
Yes, ma'am. You can proceed now.
Okay. Okay, so first of all, hello everyone. I, Prerna Kherajani, I'm here to present a case titled Bakri Balloon, an innovative approach to atonic postpartum hemorrhage in a patient with a deranged coagulation profile. About 30% of the maternal deaths worldwide are caused due to postpartum hemorrhage, and about 80% of those postpartum hemorrhages are caused due to uterine atomy. So Dr. Jans Bakri came up with an invention called the Bakri balloon, which helped to control this uterine atomy. It is a non-invasive procedure and thus helps to prevent hysterectomy in the young women. Our patient was a 24-year-old woman who was primigravida, who came to the hospital at 33 weeks of gestation in active preterm labor. She came with the complaints of jaundice with right upper quadrant pain since 15 to 20 days. Her total serum bilirubin, predominantly conjugated, was 16 milligrams per deciliter. She was a known case of preeclampsia on tablet alpha-methyl-dopa since 3 months. She also suffered from hypothyroidism since 1 year, for which she was on tablet Tylenol. She was brought to the hospital in active preterm labor. She gave no history of fever, dyspnea, chest pain, edema, convulsions, loss of consciousness, bleeding tendencies, trauma, or bleeding during the pregnancy. She gave no significant past personal or family history. At the hospital, the investigations were carried out and it was seen that she had an elevated PT-INR. Her platelet count was low, being 57,000 per cubic millimeter. She had a raised WBC count, which was 12,400 per cubic millimeter, and she had low blood glucose levels. She was given 1 dose of 12 milligram betamethasone injection IM and was left for spontaneous progression of labor under observation. She delivered vaginally and received 4 units of FFP transfusion during the interpartum period. She went into atonic postpartum hemorrhage a few hours later. She had pallor, was icteric, her pulse was 120 per minute, her BP was low, being 80/50. Abdominal examination revealed a flabby uterus. She was bleeding per vagina and she had right upper quadrant tenderness. She was given injection oxytocin 20 units in 1 finger lactate solution IV and tablet misoprostol 800 micrograms per. Injection carboprost 250 micrograms IM was given. Since her uterus remained atonic, the decision to insert a Bakri balloon was taken in view of the deranged PT-INR as well as a uterus conservation procedure. The Bakri balloon was inserted and was inflated with 400 ml of normal saline. She received 2 pints of packed RBCs and 4 units of FFP as well. Now, a few hours later, the bleeding was controlled. This is how the Bakri balloon is inserted. In case of a vaginal delivery, the Bakri balloon is inserted per vagina. The balloon is inserted first and then is supposed to be inflated. In case of a cesarean delivery, we insert the balloon through the incision that is made for the cesarean delivery. Once the balloon is placed inside the uterus, it is inflated with up to 500 ml of normal saline. This has a tamponade effect, and it causes compression of the uterine vessels. Once the bleeding is controlled, the balloon is deflated gradually and then removed. Post-Bakri balloon insertion, the uterus was well contracted and there was no bleeding per vagina. The patient's
Ma'am, we are running
vitals
out of time. Please conclude it quickly.
Yeah, the patient's vitals were stable and the Bakri balloon was removed 24 hours later. Her liver enzyme, serum bilirubin and coagulation profile normalized. These were the investigations before and after the treatment that was received. As we can see, after the treatment, her lab profile started normalizing. This was a CT scan and USG, both of which revealed a fatty liver. A differential diagnosis of HELLP syndrome, acute fatty liver of pregnancy, and viral hepatitis was reached. A final diagnosis of acute fatty liver of pregnancy was reached based on the Swansea criteria, where our patient had more than satisfied more than 6 of those criteria. She had abdominal pain, a high serum bilirubin, high AST and ALT, had coagulopathy as evidenced by the raised PT-INR, renal impairment as evidenced by the raised creatinine, hypoglycemia, appearance of fatty liver on the USG and the CT scan, and leukocytosis. Acute fatty liver of pregnancy is a very rare and fatal metabolic disorder. It is caused due to defective placental fatty acid oxidation, where there is a deficiency of the enzyme long chain hydroxyacyl CoA dehydrogenase.
Ma'am, it's 5 minutes. Please conclude it.
Which thus leads to fatty acid accumulation in the maternal circulation and leads to microvascular steatosis in the mother's liver. This is our patient with her daughter. Thank you all very much.
Thank you, ma'am. Now I request our judges to proceed with Q&A session.
Thank you, Patna, for your clinical presentation. Yeah, thanks. Bakri balloon can save women in postpartum. And during to you, clinical case. So before you put Bakri balloon, you give patient oxytocin. After you use Bakri balloon, have you used extra oxytocin or just some infusion of liquid?
No, ma'am. Once we inserted the Bakri balloon, we didn't. So basically, first we put injection oxytocin as well as carbaprost. After that, we did the uterine massage as well. After that, we inserted the Bakri balloon since she still had uterine atone. But when we inserted the Bakri balloon, we did not infuse any more oxytocin since her bleeding was controlled.
Thank you so much. And also I want to say, so have you like Bakri balloon in every gynecology hospital or like some in specialized?
Ma'am, so the Bakri balloon is actually, it's a very expensive device. It costs about 10,000 rupees in India. Since we're in a government hospital, so what we use is actually called a Shivkar pack. This was what was developed by Dr. Shivkar, where he used what is called as a condom catheter. So basically, to the end of a Foley's catheter, he attached a condom, which is then inserted inside the uterus, and then that is inflated with normal saline. So this is what is used more commonly in the government hospitals. In fact, like the use of even the Shivkar pack has it's just come into use. Like at my hospital, there have been just 12 such cases that have been performed so far. So like mine that was done was just the third such case. So it's a very new thing, and it's basically to avoid hysterectomy. And also like the other thing that could be done in case we didn't, in case the Bakri balloon didn't work, would be uterine artery embolization using interventional radiology. But luckily, the Bakri balloon worked in our patient, so we didn't have to go for the interventional radiology.
Thank you so much for your answer. And about this like device, we use like condoms for make it like for more patient. I think it's like will be useful also for your client because it's like also expensive. So thank you so much.
Thank you, ma'am.
Okay, thank you, Dr. Prerna. That was a good talk. No questions. Thank you.
Thank you so much, ma'am.
Thank you, judges, and thank you, ma'am.
Thank you.
Lastly, to conclude this, first, I'm very sorry, judges. It took more than 20 minutes than expected. And I would like to thank our judges, Dr. Richa Chauhan and Dr. Lolita ma'am, for presenting here and contributing their really, really valuable time in spite of their really busy schedules, and have attended this seminar for the sake of our budding doctors and beloved medicos. I sincerely thank you all on behalf of our SMR and all our participants. Lastly, I would like to thank all our participants for their enthusiastic participation.
Yes, please. Please.
Yeah, can I? I want to also thank you for organized committee.